Good evening, everyone. I'm Dr. Beruzi, a member of United Optometrists Forum Advisory Committee, a vision care consultant, and a contact lens specialist dedicated to advancing educational and professional development in eye care. It's a pleasure to be your host for today's session by Zeiss Vision Care. We are delighted to have our first speaker of the session, Mr. Rashid Zaroor, General Supervisor of Al-Battle Optical Company, who will be sharing valuable insights on the topic Experience Zeiss Myopia Management with Dr. Battle. Please join me in welcoming Mr. Rashid Zaroor. Thank you.
Hello, everyone. Good evening and Ramadan Kareem to all. I am Rashid Zaroor. I am the General Supervisor of the Optical Branches in Al-Battle Optical Company. And today I will be sharing with you a presentation. Let me just share my screen very quickly. Okay, so the title of my presentation is Experience Zeiss Myopia Management with Dr. Battle, and it is a strategic approach to myopia management at Battle Eye Center, located in Jeddah in the Kingdom of Saudi Arabia. So, in the beginning, a very brief introduction for myopia. We all understand by now that myopia has become a global epidemic, and it's expected by the year 2050 that nearly half of the global population is expected to be myopic. Why is it important for us to incorporate myopia control into our practices? Because reducing the risk of vision-threatening complications associated with high myopia. And what is our role as the Battle Eye Center and the Zeiss Vision Center with the Zeiss Myopia Management Workplace? We are pioneering advanced myopia management in the Kingdom of Saudi Arabia. Now, to delve a bit deeper into myopia and understand its progression. According to the IMI, the definition of myopia, it is a refractive error in which light rays entering the eye parallel to the visual axis are focused in front of the retina when the accommodation is relaxed. Some of its risk factors are genetic or environmental. Some are associated with more near distance reading distance time, usage of digital devices, and insufficient outdoor activities. Some complications of high myopia, they include the increased risk of retinal detachment, glaucoma, and myopic maculopathy. Now, to be more specific about the prevalence of myopia in the Kingdom of Saudi Arabia. There are many studies that have been performed, but these are like the, let's say, the summary. So in the general population, the prevalence of myopia was found to be between 4.5% to almost 35% among different age groups. But when we go even to be more specific, we look at children, and it is found that the prevalence of myopia among Saudi children was found to be 40.7%, which is a very, very high number. While in university students, it even went up as high to 53.5% prevalence of myopia. So what are we, where are we located, what are we doing? So we are our location is in Jeddah, Saudi Arabia, and it is a partnership between the Battle Eye Center and Zeiss. Our mission is to deliver evidence-based myopia control solutions, and our target audience are children, parents, and healthcare professionals. Our implemented strategies are as the follow. We have patient education, which is informing about myopia risk and management options, lifestyle modifications, which encourage outdoor activities and regulate screen time, and the use of peripheral defocus lenses, which are the MyoCare and its soft design, the MyoCare S, which include the care elements, which is the circular annular, the care elements to slow progression. The cylindrical annular refractive elements. So, what is the protocol at Al-Battle Eye Center? First and foremost, we do a comprehensive eye examination, which is detailed patient history, cycloplegic refraction, binocular vision evaluation or assessment, fundus examination to look out for any retinal changes associated with high myopia specifically, and last but definitely not least, axial length measurement using optical biometry for progression monitoring. Next, we go to our myopia control strategies. patient education on myopia progression and associated risks, lifestyle modifications, including outdoor activity recommendations and near work management, and optical interventions with Zeiss MyoCare lenses, which are the peripheral defocus lenses with the care elements. And then our follow-up and monitoring strategy. We have every 6 months a regular follow-up to reassess myopia and its progression. We have axial length tracking to monitor myopia control efficacy and adjustment in treatment strategy based on the progression trend. We have some initiatives which of training and education. We start with parental counseling and awareness. Parents receive personalized counseling during their child's eye exam to understand myopia risks and available control options. We provide printed educational materials and digital resources to reinforce key messages at home. Parents are guided on screen time management, outdoor activity recommendations, and the benefits of Zeiss MyoCare lenses for effective myopia control. We have our regular follow-ups and reinforcement again. It's every 6 months to track progression and adjust any interventions and reinforce compliance. And parents also receive reminders through SMS and social media updates about their follow-ups. We also provide workshops and training sessions for the staff at the company. So we have regular training sessions to ensure all staff are well versed in myopia management protocols and patient communication. Workshops which include updates on Zeiss MyoCare technology, axial length monitoring, and best practices for patient education. And last but not least, staff members are trained to provide consistent messaging and support to patients and parents, improving compliance and patient outcomes. We also provide educational videos and digital outreach. We create and share informative videos about myopia control, lifestyle modifications, and early intervention. These videos are posted on our social media platforms and website, making evidence-based information accessible to parents and patients. And this is just a very little example.
اللي تسمى بعدسة المايوكير لعلاج قصر النظر عند الأطفال وبالتالي تبطيء عملية زيادة قصر النظر. أتمنى لكم السلام.
So, we'll be talking about some challenges and solutions when it comes to myopia management with its practical implications. So, first and foremost, managing patient and parent expectations. A lot of people think that they expect quick results or a complete cure, leading to frustration or dropout. The solution to this would be, we have to clearly explain that myopia management slows down progression and does not reverse it. We need to be using visual aids and reports to track axial length and demonstrate progress. And we need to be training our staff to set realistic expectations and reinforce the need for long-term commitment. The second challenge could be cost and accessibility. Some parents find myopia management to be quite expensive, impacting their willingness to proceed. The solution could be offer flexible payment plans and bundle packages to improve affordability, highlight the long-term benefits of reducing future eye health risks, which are associated with high myopia. Explore insurance partnerships to integrate myopia care into standard pediatric eye examinations. So in summary, the rising myopia rates in Saudi Arabia call for early intervention, and it is very essential to slow progression and reduce future risks. Comprehensive myopia management is a structured approach which includes detailed eye exams, axial length measurement, lifestyle counseling, and optical solutions. Effective patient and parent education, which needs to be done through clear communication and realistic expectations, improve compliance and long-term success. We need to be addressing key challenges, which is managing expectations and improving accessibility are crucial for better patient outcomes. And our center's commitment, Battle's Eye Center commitment, we are combining advanced technology, expert care, and education to lead myopia management in Jeddah and soon to be in all of the Kingdom of Saudi Arabia. Thank you so much.
Thank you, Mr. Roshan. I'm Jabin Jaffer, Executive Member of United Optometrists Forum. I would like to request our next speaker, Mr. Tanios Georgios, to speak about new times needs new technologies. Over to you, Mr. Mr. Tanios?
Yes, hello. Good afternoon. Can you hear me, please?
Yes, you are audible.
Okay, perfect. Can you see my screen?
Yes, it's visible.
Okay, perfect. Good afternoon, everyone. And it's always a pleasure to be with you. It's an honor to be with you. And again, it's a big pleasure to be one of these sponsoring of Myopia Conclave online metaverse event organized by United Optometrist Forum. My name is Tanios Georgios, and I am the training manager for Amico Vision Care Middle East. So I will be talking to you today for 20 minutes about new times need new technology when it comes to contact lenses. So as you all know that everything in the past 20 years has changed in our life. Everything has changed. And the way we talk, the way we communicate, and the way we order food, everything has changed. And if you look to these beautiful devices here, we all recognize and we remember these beautiful devices here. They were the first mobiles that we bought. And I'm 100% sure that almost no one is still using these beautiful devices. Nokia, Ericsson, Motorola, BlackBerry, the old good days, as we say. I just want to ask loudly, and I will answer, but I want you also to rethink with me. Is this was a bad technology? Definitely not. We all remember the first time when we had our mobile. That was a great technology. We were really surprised. But after maybe 25, 30 years, no one is still using. We all moved to digital devices. We all moved to smart technology. We all moved to smart devices, and we want more from our mobiles. We need to do the same also when it comes to contact lenses. We should do the same when it comes to contact lenses. I just want you to, again, to remember that when we started using soft contact lenses, we started with hydrogel contact lenses. And hydrogel contact lenses used to have a lot of benefit. It used to be hydrophilic, but the problem used to be with very low DK over T. That was the patient used to have vascularization, used to have red eyes, and especially they used to dry out very fast at the afternoon. But before that, 25, 30 years back, no one used to use contact lenses for 12, 15, 16 hours per day. So it was good. But after that, they started using contact lenses for a longer period. And the companies, the big companies, they start switching to silicone hydrogels. So silicone hydrogels used to provide us with a lot of oxygen to the cornea. So the DK over T was high. So we had a better ocular health. But the problem, the silicone hydrogel is a hydrophobic material and needs treatment. So it attracts lipids and deposit and it provides always a high friction on the surface. So we solved the problem of the ocular health, but we fall in another problem, which is the treatment of the contact lens and the high amount of silicone on the surface. So the latest technology in the world of contact lenses is water surface lenses, which a combination of hydrogel and silicone hydrogel, where the contact lens is a lot of silicone in the core of the contact lenses to provide a better ocular health, but with a high water content on the surface. And that's why we call it water surface lenses. The problem now is the market in the Middle East is still dominated by hydrogel and silicone hydrogel. So that's the problem. The problem is in our stores, in our facilities, in our clinics, we are still providing our users in 2025, in this year, we are still providing them with a technology that has been produced 20 or 25 years back. And that's our topic today. We need to upgrade these customers. We need to provide our users, our patients using contact lenses with new technologies. We cannot keep them on, if you kind of compare it to mobiles, we cannot keep giving them Motorola and Nokia and Ericsson and BlackBerry. We need to switch them to something new because their life has changed. Now, what's the problem? Why we are not doing this? why still 70% of our users still using hydrogel and old silicon hydrogel contact lenses? Why they still didn't move to water surface lenses? We as eye care professional, we always have this struggle. Oh, it's time consuming. Oh, there is a lot of investment coming from the customers. Oh, the customer is not complaining. We should stop thinking about the time consuming. Our biggest asset is the user, is our customers. When the customer is satisfied, our business is satisfied. So time consuming is nothing. No, we should give some time to our customer to tell them that there is something new. We should not say, oh, if I'm going to speak to my customer, if I'm going to speak to the contact lens user, if I'm going to offer them something new, this is going to consume my time. No, you are investing some of your time. You are investing 5-10 minutes of your time to speak to your customers, to know about their problems, and to offer them something new. And always try to start from the start with the right lens. Always start with the new users with the right technology. Start with the latest technology. Do not put any more contact lens users or new contact lens users on hydrogel, on silicon hydrogel, because these customers, they're gonna drop out. You're gonna be wasting your time because 20 to 30% of your customers, they will not feel good about old technology and they will drop out. So with the old users, take some time, talk to them about new technologies, tell them that there is something new about in the world of contact lenses. And also, whenever you are fitting a new customer, just directly start with the latest technology. Now, about the investment, please do not be afraid that the customer will not pay. The customer will pay the extra money. The studies are showing that 76% of the customers, they are open to the idea of paying more for innovative contact lenses, but they need to understand why. They need to understand the benefits that these new contact lenses they will provide, and they will be ready to pay the extra money. And this extra money is going to be a small investment versus all the benefits that they're going to take. So people, they are ready to pay, but they just need to know why. Also, sometimes we say, oh, my customer is still coming to my practice, he's coming to my clinic, and he's still ordering old contact lenses. So if it's not broken, do not fix it. No, it's not the case. The customers, they don't know what's new. So they keep asking for old technology because they think that these technologies are the best. But 88% of, this is the latest studies again, that 88% of the ECPs, the eye care professionals, they think that contact lenses discomfort needs to be taken seriously, but only 33% they take action. They open the conversation. So we all know that people, they have problem, but very few of us, they take some time to discuss the discomfort with their customers. And so there is a miscommunication or disconnection between the eye care professional and the contact lens users. Please, you as eye care professional, we as eye care professional, we need to start the conversation. Just very easy. Just ask your customers, what's happening at the end of the day? Are you feeling your contact lenses at the end of the day? Are you using eye drops? Do you have any redness? Do you feel your contact lenses? If any of these questions is yes, that means your customers, they have a problem. And for these problems, we have the solutions. So for science to discuss new lens technology, if people, they are still using hydrogel or traditional silicon hydrogel, if they had to remove their contact lenses earlier during the day, if they are using wetting drop, if they are feeling eye strain when they are using digital devices, any of these signs, that means they have a problem and you need to fix it. Let's remember, all of us, that we blink over 14 in a normal day. We blink over 14,000 times per day. But when we sit on digital devices, minus 60% blink rate, and this is causing a lot of dryness. And when people, they are using contact lenses, that's a problem. And if they don't have a solution, they're going to drop out. So that's what we said. The customer's life is changing, and we need to change the contact lenses. 25 years back, the patients didn't spend 8 hours plus using digital device, their smartphones, their tablets, their computers, their smart TV. Now everybody, me, you, and your customers, we are using digital device for 8 hours plus during the day. And we need new technology in the world of contact lenses so we can keep having a good comfort with a very good vision. Otherwise, your customers, they will have discomfort and they will stop using contact lenses. Who's going to solve the problem? We, as eye care professional community, we count on you to start the conversation. Just start the conversation, everything else will happen. So what Alcon, what is providing? This is the latest technology in the world of contact lenses. We are providing a new technology. It calls water surface lenses. And it's a full portfolio. It's very different than all traditional silicone hydrogel, where the core of the contact lenses, inside the contact lenses, is different than the surface. In all traditional silicone hydrogel, the surface of the contact lens where we blink used to be the same as in the core of the contact lenses. Now with this new technology in Alcon portfolio, in daily disposable and in monthly, and it's available also in sphere and in toric, the core of the contact lens is totally different than the surface. And I'm going to take one example because this portfolio is almost the same. It's all called water surface lenses. So I'm going to talk for a particular contact lenses, which is Dailies Total One. It's a one-day contact lenses. So everything that it's relative to Dailies Total One, it's almost the same concept in the other contact lenses for the full portfolio. So what's new about Dailies Total One? Why we changed the technology and what is beneficial to our customers? So in Dailies Total One, the core of the contact lenses is silicone. So inside the contact lenses, as you can see, there is only 33% water, and all the white area, all the other white area is silicone to provide a lot of oxygen to the cornea, to keep the cornea healthy, to keep the white and healthy eyes. But where we have the friction, where we blink for 14,000 times per day, it's 100% water on the surface. So nothing is touching the eye beside a cushion of water. And also on the back surface, where it's touching the cornea, it's also 100% water. So it's a unique technology where we are providing the highest oxygen transmissibility to the cornea and also the highest water content on the surface where the contact lens is touching the eyelids and the cornea. But they didn't stop here. They added another technology, which is the Smart Tears technology. This contact lens is also unique. It has phosphatidylcholine. It's almost, I just want to simplify the message, is like having eye drops inside the contact lenses. So whenever the contact lens is going to feel that the eyes is getting dry out, so instead of using eye drops, this phosphatidylcholine is going to be released automatically from inside the contact lens to the tear film to regenerate the tear films automatically without the use of any external material like eye drops. So the contact lens will keep the eyes even in hard environments like digital devices, like a lot of exposure to the air condition. So it's going to keep the eyes wet, and the patient will keep enjoying, again, very good vision and a lot of comfort without use of eye drops. So these contact lenses, the patient can use it for up to 16 hours per day. Okay? And it has a superior tear film stability, superior end-of-day comfort. So again, the life of our customer is changing, and we need to change also the contact lens with it. We cannot keep the same contact lenses for over 25 years and saying that the customer is not complaining. He's happy with what he's having. They are not complaining because they don't know that there is something new. Please, it is our job to tell them that there's something new. Otherwise, we're going to lose these customers. Either they're going to drop out, or somebody else will come and tell them that there is something new. So if you want them to keep them loyal, you need to talk to your customers. Start the conversation. So this contact lenses is, again, a unique contact lens. It has 100% water on the surface. It reduced the lens-related dryness symptoms. It has the highest oxygen transmissibility in all daily disposable. It has a DK over T of 156, the highest in daily disposable contact lenses. So how to get the most out of our partnership in Amico and Alcon is just start the conversation, ask for trials, because we highly believe that trying is believing. Everything that I said is beautiful, but believe me, it's going to be more beautiful when you put the contact lenses in the eyes of your customers. Okay, so please feel free to reach out for Amico, order trials, fit your customers, and upgrade your contact lens users to technology like water surface lenses. So this is and again, these three lenses, Precision 1 and Dailies Total 1, they are daily disposable contact lenses, and Total 30 is the latest technology also in the world of monthly contact lenses. So we have everything that your customers need in spherical, in myopia, hyperopia, and also in toric for astigmatic patient. And with that, I say thank you, all the best, and I have still another presentation after 2 hours. So see you then. Enjoy your program. Enjoy your day. Thank you.
Thank you, Tanios.
Thank you.
Okay, good evening, everyone. Hope you're enjoying the symposium until now. I'm Irene Joseph, specialist optometrist in Dubai, and also member of the scientific committee of UOF. I'm excited to welcome you all to this debate session, where we will engage in some thought-provoking discussion on which is a better option for myopia control, contact lenses or spectacles. Our speakers have prepared some compelling arguments backed by research and reasoning to defend their stance. I encourage everyone to listen attentively and consider both sides before making your decision. All right, to speak for contact lenses, we have Mr. Yashwant Saoji from Saoji Vision Care, India, and we have Kausalya Akina to speak for spectacles, optometrist from L.V. Prasad Eye Institute, India. So let's start, Yashwant, with your thoughts on contact lenses.
Yeah, Irene, it has to be contact lenses. Why the hell this debate? You know how contact lenses function. Basically, myopia progresses due to the hyperopic defocus. And these contact lenses, which are special contact lenses, which either create an imprint on the patient's cornea or they have a +4 ring on the front surface of the contact lens itself. And this +4 ring, either on the cornea or on contact lens, helps in eliminating the hyperopic defocus and sometimes even creating a myopic defocus. And plus, look at the added advantage of removing your glasses. No need to wear glasses. So cosmetically appealing, very effective in controlling myopic progression. And lenses like orthokeratology, you have to sleep in them. So you're wearing it in controlled environment. And there are so many options available. It could be your regular multifocal, which is center distance multifocal. It could be the EDOF multifocal or the soft ortho K lens, which have got a +4 ring on the front surface. Or it could be the daytime RGP contact lens having a +4 ring on the front surface. Or the best one, the ortho K. Sleep with the lens on, control your myopic progression, get rid of your glasses. It's contact lens for sure.
All right, Yashwant. Kausalya, let's hear from you about spectacles.
Well, Ashwin, hopefully the spectacle will be the winner of the show. You know, the spectacle correction is one of the cornerstone of primary eye care in optometry. So especially myopia progression can be corrected and controlled with myopia controlling spectacles. Myopia spectacle technology developed has evolved significantly from past 19th century to till date in terms of slowing down the progression. If you look back into the 19th century, it started with smart bifocals and progressive edition spectacle lenses. It helps in controlling the lag of accommodation by incorporating the accommodative lag theory. In 20th century, there is a peripheral defocus spectacle which has emerged out. There is a competition between the different technologies where initially the DIMS technology has come out. It's a defocus incorporated multiple segments. There will be a wide 9 mm zone with the lens light surrounded, and there are spaces in between. Later, with advanced technology of HALT, a highly aspheric lens slits, followed by the dot technology, which incorporates the diffusion optics and all. It helps to increase the contrast at the retinal level. And at last is the care technology, which helps to eradicate the higher order aberrations in the peripheral retina. Do you think there's many options are there in the spectacles still we need contact lens? I don't think so. We need contact lens option.
What do you think, Yashwant? Looks like
With
too
so
many
many
options.
options in glasses,
Are
it's
there
so
any
confusing.
advantages
In contact lens?
in contact lens over spectacles? You think there's any specific advantages?
Oh, all are advantages, Irene. And the biggest one is cosmetic. No need to wear those thick, unsightly glasses. And plus, excellent myopia control. And with so many glasses, it's so confusing. Which one should I give? Should I give this technology or that technology? When it comes to ortho, it's only one simple lens, takes care of everything. And plus, just imagine we are giving these lenses or these options to kids, and they love to play outdoors. Now, outdoor sports spectacles are a hindrance. If the child is getting rid of wearing glasses, is it not great? They can play sports completely free of wearing glasses. I think it's a
Device-free daytime, right? Optical device-free daytime. That's what you're getting at. If it's an ortho K lens,
yes. So
it's different
nighttime
when
you
it's
wear
a
lenses.
soft day lens. It's
Even
different
if
when
it's
it's a soft day lens.
it's a soft day lens. Also, you don't need to wear glasses. They're moving with the movement of the eyes. Your dynamic vision is much
Let's
better.
talk about
All are advantages.
safety aspect. Let's talk about safety aspect.
Okay.
You think, Kausalya, do you have any points to say spectacles are safer?
Yes, of course, because the spectacles are all time children friendly and it's fashionable. They can change the colors of frames and they can select the shape of the frame, and it's just like this, like Rajnikant wears like glasses. You just need to put spectacle and then children can be able to see the world clearly. There is
So it
no
looks
long
like
process.
fashion with spectacles is also possible. But let's see. Yashwant, do you think contact lenses safety factor?
Yes. See, Irene, our eyes are made in such a way that the eyes go inside the socket. So even if there is an injury, it's the orbital plate which breaks first. So not wearing any glasses, very good for sports. Because remember, these glasses are not 100% unbreakable. They are polycarbonate. They are high impact resistant lenses, but they can still break. And what happens while running if the glasses fall off? They can fall off, right? Then what happens? You're not able to see anything where you're running, where you have to catch the ball.
So it looks like there are concerns of safety in both options.
Dynamic vision is much better when it comes to contact lenses. For any sports, contact lenses definitely score over glasses.
And what about in terms of myopia control with the lenses, design, spectacles? Kausalya, you have anything to say about that?
In terms of spectacle options, all time the efficacy stands high compared to contact lens because there are various studies having various technologies have various efficacy options. So in terms of defocus spectacles, they're like 60 to 70% of efficacy with spectacles within 1 year is rated in children, but there are very lack of evidence in contact lens customized studies that shows highest efficacy that children can have with myopia progression.
Or you talk to anybody who's wearing ortho K lenses, they would swear by it. The myopia just doesn't progress. It gives amazing results. And plus, Irene, how do we control myopia? We have to eliminate the hyperopic defocus, right? I think there is no argument regarding that. Now you want that plus 4 to move with the movement of the eyes. In glasses, the glasses are stationary. So if the child is not moving the chin and looking through the peripheral portion of the glasses, the defocus is gone for a toss. Whereas in contact lens, you're imprinting that plus 4 ring surrounding the pupil. So wherever the child is seeing, the hyperopic defocus is being eliminated. I think that's a big plus. It's actually the plus ring which helps. It's a very big plus in contact lens that helps.
All right. That's the point. Kausalya?
Well, to counteract the point, like where the contact lens moves along with the eyes, in the peripheral defocus glasses, there is a defocus area which is incorporated. So the light which is interacting the eyes has interaction to the retina. The defocus can triggered in the periphery too. The defocus is helping. It's not like it's not helping. If they move the eye, then only the defocus will be more. So, and then it comes to the blur in the sight. So we just recommend a simple idea that child you just move a little head movement to see the things clear rather than moving to the eyes. The defocus will be perfectly working, I think. Yeah.
So that's not the natural movement. That's not the natural behavior. So you have to adapt to glasses. Whereas contact lenses give you complete freedom. You can be your natural self.
It's not about
And what about the
adaptation.
duration? What about the duration for myopia control? How long do you think the child needs to wear contact lenses, or how long should they wear peripheral defocus or other types of glasses?
See, normally when we discuss about orthokeratology, you can wear all your sleeping hours. And normally a person sleeps about 6 to 8 hours. Kids normally sleep for 8 to 10 hours. That's good enough. And today the technology is so advanced that we can design lenses wherein you can just sleep for 5 hours and still there'll be very good effect. But generally,
what about the long-term
all throughout the
usage?
night.
I'm not asking about the wearing schedule for every day, but how long the child needs to use this modality for good myopia control?
Well, I think that's directed to me or to her.
Both of you. You can go, Yashwant.
Okay. So duration for myopia control, I think the answer is similar for both of us. Until and unless the axial elongation stops, we have to continue the therapy. So it is not dependent on glasses or contact lenses. You have to keep measuring the eyeball growth every 6 months. And once you have stable readings for 3 or 4 times, then maybe you can try and discontinue, but keep your measurements on.
Is there an advantage in any of the modalities for once the child is over 21 years of age and they want to go for other options of myopia correction, say refractive surgery? Is there any restriction with any of the modalities? Kausalya?
Yeah, when it comes to maybe the rare aspect of myopia management is when to taper, when to cessate, when to stop. Either it's contact lens curiously, like fashion the spectacles, but it's very important that all-time monitor the axillin changes, the refractive power, and keep a watch whether they are under control. If everything looks fine in a year, maybe they are good to go late teenage, like 20. Even adults can have triggered myopia progression even at the late adult age, like who have excessive near activities and all. But the point to make out here is the extended power range, that cylindrical power of -4 that cannot be available in contact lenses. At times it will be difficult in dispensing the contact lens, so in that case the spectacles helps better. In such cases, even the ortho-K is an extraordinary option.
Okay, so in case if you have any -4, if she has any -4 patients, then she can refer them to me. I can fit them with lenses very comfortably.
So basically, lenses can be customized also for astigmatism.
Yes.
And all time they need a backup of spectacles too for ortho-K at times. Yeah.
Okay, now that we've heard the various points, we see both has advantages and their challenges, and we've heard this excellent argument between the two speakers. So that
now
brings us to the end of the session. So we will not decide. We will not decide. We're going to let the audience decide on who is the winner of this. And before we end, I'd like to just say a small point that debates such as these sessions reminds us that critical thinking and the willingness to consider different viewpoints are very important as a person also for growth and progress. Just want to make that one point. And now we will display the poll so the audience can take up the poll and give their opinion on this argument. Thank you. Thank you, Yashwant. Thank you, Kausalya.
Thank you.
Thank you.
Good evening, everyone. Ramadan Kareem. Happy World Optometry Day to one and all. I am Palaniappan Lakshmanan, currently the Vice President of the United Optometrists Forum. I will take you through the next session of the evening. The next section is going to be about the Myopia Chronicles, Real Cases, Real Insights. So the first topic of the session is about the relationship between myopia severity and the oculomotor function in children by Dr. Saif Rashid. Dr. Saif Rashid is working in Qasim University College of Applied Medical Sciences, Saudi Arabia. Over to you, Dr. Saif Rashid.
Are you hear me?
Yes, sir, you are audible.
Okay. Okay, thank you for United Optometry Forum for inviting me to present my lecture on or my presentations on impact of neuroxyphoria, vergence, and accommodations on myopic severity. Yes, here my presentation outline. First, we're going through introductions. We will show about myopic accommodations, convergence, and near work. Yes, near exophoria and myopia. Yes, this yes original article. We're going to methods and result, and in result we focus on parental history of myop, correlation between near exophoria and myopia, accommodations amplitude, and myopic severity, near point of convergence and myopic severity. Finally, we'll go through discussion on clinical implications and management strategy for myopia. And finally, we see the conclusion or key message. Yes, the current increase in myopic among children is a major public health concern worldwide. This could be because of a significant amount of time that child spent in their work activities such as reading and using a smartphone, as my colleague in the previous lecture discussed this. Yes, a recent study shows that the genetic and environmental factors such as time spent outdoor are the main reason for high prevalence of myopia. Yet a recent systematic review and meta-analysis found high myopic rate or high myopic prevalence in the children in Asia, about 60% myopic prevalence in Asia, more than in North American, and yes, in North American about 42%, and in Europe about 40%, but less. Sorry, I have some maybe technical issues. Sorry.
No problem.
Are you hearing me now?
Yes, it's visible.
Okay. Sorry.
Just go to
Holding expect that by 2015, approximately about 50% of world population will be myopic. Myopic is leading causes of visual of in developed country, and most causes of treatable blindness in poor nation. A recent systematic review and meta-analysis found high prevalence of myopia in extramaternal region children, especially older one and female, and the study recommends that early investigations is critical to prevent loss of visual impairment. Yes, myopia accommodations and convergence and near work. Yes, a rule of accommodations mechanism in myopic populations have been a focus of research in recent years. And near work, as you know, that the near work initiate accommodation as I adjust to achieve clear image when accommodative response is lacked. Sorry.
Start with your presentation.
Sorry. Sorry, I'm not hear you.
I think you can continue.
Okay. Yes, when accommodation response is lack, result clear retinal image is sorted to be trigger axis elongations and contribute to development of myopia. Yes, understanding accommodations and conversion mechanism is very important as the near visual activity are fundamental to development of myopia. Yet, a recent study suggests that both accommodative inaccuracy and accommodation inability may contribute to development of myopia in children. Yes, after prolonged focusing on near object accommodation, relaxation. No problem. Are you now?
Yes, it's visible.
Sorry. When accommodation response is lack, result clear retinal image is sorted to be trigger axis elongations and contribute to development of myopia. Yes, understanding accommodations and conversion mechanism is very important as the near visual activity are fundamental to development. Sorry, I found some difficulty. I don't know. Study suggests that both accommodative inaccuracy and accommodation inability may contribute to development of myopia in children. Yes, as this mechanism is very important as the near visual activity are fundamental to development. Sorry, I found some difficulty. I don't know. Study suggests that both accommodative inaccuracy and accommodation inability may contribute to development of myopia in children. Yes, as this mechanism is very important as the near visual activity are fundamental to development. Sorry, I found some difficulty. Accommodation inability may contribute to development of myopia in children. Yes, as this
Thank you, Dr. Saif Rashid, for the insightful talk. The next topic of this session is about pharmacological management of myopia in children in the form of case study by Dr. Alan Mulville. Dr. Alan Mulville is a consultant pediatric ophthalmologist working in Al Jaliliya Children's Hospital in Dubai. Over to you, Dr. Alan.
Hello. Can you hear me, first of all?
Yes, we can hear you very well.
Good. Okay, well, thank you very much for inviting me. I'll try not to go over any of the ground that's already been covered, but I will just allude a little bit to theories of myopia. So as I've been introduced, I'm Dr. Alan Mulville. I'm a fellowship-trained pediatric ophthalmologist at Al Jalila Children's Hospital. And we do quite a lot of myopia management here. I think we'll have seen this slide or something similar to it on several occasions this evening. Everybody knows that myopia is increasing. It varies from almost universal in parts of Southeast Asia to very prevalent in Europe and North America and Gulf states, and maybe somewhat less in other countries. I think it's generally agreed that myopia seems to result from increased axial length of the eye. What's a little less certain is exactly how that happens and why it's becoming more prevalent. In the past, myopia was treated simply by trying to give a more clear focused picture on the fovea. And in more recent years, it's become clear that the situation is a bit more complicated than that. Myopia probably depends on genetics. If you've got one myopic parent, you're more likely to be myopic, and even more so if both parents have myopia. It also probably relates to lighting conditions, that time spent in natural light is probably protective, whereas artificial light probably encourages the development of myopia. Probably simply because even the best artificial light doesn't match the intensity of natural outdoors light. Form deprivation has a role to play. And in recent years, we've become particularly interested in peripheral hyperopic defocus. In other words, while the fovea gets a clear image from contact lens or monofocal glasses, the peripheral retina is not in focus, and this is felt to be one of the principal drivers for myopia. The idea of atropine treatment for myopia has certainly increased a lot in the last 10 years, but even before then, it's been around for quite a long time. Going back a few decades, there were a small number of doctors treating a small number of patients with quite strong concentrations of atropine eye drops, usually 1%. And needless to say, this caused blurred vision, especially near vision, and also light sensitivity. And because of the blur, the loss of accommodation of blurred near vision, kids would have to be given progressive power lenses, glasses lenses, or bifocal glasses. This remained a
Dr. Allen, please, can you share your slides?
Oh, sorry.
Sorry.
Hold on. I thought I was. Hold on. Right. Okay. Can you see them now?
Yes, we can see them very well. Thank you.
Okay. Apologies for that. I could see them. You couldn't. Anyway. So atropine, around for a long time. 1% atropine was the sort of only option available until relatively recently. And how it acts on myopia is not fully understood, but it's thought to help reduce the increased axial elongation of the eye, and probably acts either directly or indirectly on the retina or sclera to inhibit growth of the eye. Modern atropine treatment was really kind of large off by the ATOM trials in Singapore. ATOM 1 involved 1% atropine drops to children nightly over a 2-year period. It slowed myopic progression significantly and reduced axial length elongation. ATOM 2 was a more nuanced trial. It demonstrated that both 0.5%, 0.1%, and 0.01% atropine slowed myopia, with the stronger concentrations having a greater effect over a 2-year study. However, when the treatment was stopped, there was rebound in myopic growth that was greater with the higher concentrations. I think everybody's probably familiar with this slide of atropine concentrations, the effect of different atropine concentrations on myopic progression. And when the treatment is stopped, there is rebound that is much less with lower concentrations of atropine. And as per the ATOM study, particularly with 0.01%. And that's why it's become the sort of first line concentration or go-to concentration of atropine. And needless to say, with the 0.01% atropine, the effects on pupil dilatation and near focus were minimal to well, basically negligible. I've yet to encounter a single child who's volunteered symptoms of blurred near vision on 0.01% atropine. It's extremely well tolerated. A more recent trial looking at a variety of lower concentrations is the LAMP study from Hong Kong, published in 2019. And they looked at 0.01%, 0.025, and 0.05. And again, all were effective, with the higher concentration being, not surprisingly, more effective. But again, some rebound with all after stopping treatment, more so with the higher concentrations. But there's a sort of, there seems to be a sort of happy zone with these reduced concentrations and less rebound. Overall, atropine, low-dose atropine is very well tolerated, but it doesn't work in all children. And I think there's some work necessary, including, I think we need good figures for the Gulf states. And there's lots of work from Southeast Asia, there's some work emerging in North America and Europe. But I have to say, our experience in Al Jalila has been very positive. Essentially, how we treat myopia is we if they've an increasing myopia by 0.75 diopters or more over a 6-month period, we offer treatment, and the vast majority of parents are keen to try. They have a baseline subjective and cyclorefraction. We measure their axial length and the IOL master, full examination of the front and back of the eyes. And they're started on 0.01% atropine once daily to both eyes. And they're seen 6 monthly by an optometrist and have repeat refraction and axial length. What's the earliest age you might start? Probably 4 to 5 years of age. They need to be old enough really to go on the IOL master. We know that myopia can progress very much at these lower ages. So I think it's important to think about myopia treatment if you identify myopia at this younger age. We tend to continue treatment for at least 2 years if it's working, if it's stopping the myopia from progressing. And after 2 years, if they're stable, stop atropine and switch them to one of the optical lenses that address peripheral hyperopic defocus. Overall, our experience with atropine has been extremely positive, and the vast majority of children who are, and I have to say in our hospital, the vast majority are Emirati children. The vast majority seem to respond well to 0.01% atropine, and only a small number do not respond, in which case we increase the dose to 0.05% atropine. To the best of my knowledge, the only dose commercially available currently in UAE is the 0.01%. So 0.05% atropine has to be compounded in our hospital pharmacy, and we're very lucky that our pharmacy is able to do this. But it relies on them having access to 1% atropine drops, and there was a shortage for one stage in 2024, which stopped us from using this for a while. While I was researching the study, I came across something that I was unaware of, which is a new oral management therapy, which is being trialed for myopia. I'm not sure if anybody's aware of this, a medication called ND10, which is said to increase the biochemical strength of the sclera and prevent elongation to inhibit myopia progression. And apparently it shows greater clinical efficacy in comparison to optical devices and topical medications over a 3-year period. One of the reasons this caught my eye is that the company responsible, Thea Life Sciences, seems to be based in Dubai, or certainly has a significant presence in Dubai, though I was unaware of this study. The theoretical basis for how this medication acts is that it antagonizes adenosine receptors and upregulates dopamine, which stimulates the synthesis of collagen-1 and fibronectin in scleral fibroblasts. I'm not sure if there's any actual publications on it so far, but I was just thought it was interesting and I would raise it. My feeling is with any oral therapy is that parents would be much less likely to go for some long-term oral therapy than they would for long-term eye drop that doesn't sting and doesn't blur the vision, though I could be wrong. Overall, the greatest consideration is, well, atropine drops definitely work well for certainly the great majority of children in UAE, but not all. I'm pretty sure that the efficacy varies with ethnicity, and Emirati kids seem to respond well to 0.01%, as do most Caucasian kids. I think Asian and Southeast Asian ethnicity may require stronger concentrations. But even with all this, we're not actually reducing the myopia, we're just reducing the progression or the increase in myopia. And how much effect this will have long-term on the complications of myopia, nobody knows at all, whether it reduces the risk of retinal detachment, myopic macular degeneration, and so on. I'll have to say, the lower the myopia, the better, because there's a linear increase in risk of all these complications with your degree of myopia. So it's definitely worth trying. Okay, thank you very much. Any questions?
Thank you. I think now we will give some time to Dr. Saif to finish his presentation. There was a technical glitch and we still have some time. So please, Dr. Saif,
Okay, thank you. Now you hear me?
Yes, we can hear very well.
Okay, thank you. I'm sorry for technical issue. Yes, now we jump on nearexphoria and myopia. As you know that a child age 6 to 12 years typically hold the reading material about 10 to 40 centimeters away. This with constantly short reading distance are more likely to develop high level of myopia. Yes, the nearexphoria, as you know, that is the binocular conditions where their eye diverted outward during near task is commonly reported in children with myopia. And there is some complex relationship between myopia, near work, and exophoria. Exophoria can also disrupt binocular vision, causing symptoms like blurred vision, double vision, and eye strain due to prolonged close work. Yet, near work, which induce activated accommodations and vision system for clear and single binocular visions may contribute to development of child myopia. Yes, this presentation is aimed to investigate the relation between myopia severity, near exophoria, near point of convergence, and accommodations amplitude in the children. This study was is a hospital-based study, cross-sectional hospital-based study conducted in Al Eye Hospital in Khartoum, Sudan. Yes, the study include 117 myopic children, their age between 6 and 15. The ophthalmic examinations include autorefractometer for assessing the refractive error and confirmed by retinoscopy, slit lamp. If any child have any ocular disorder excluded from the study. Measurement of accommodations were assessed by push-up method. Accommodations and near point of convergence was assessed by push-up method. Near foria was assessed by alternative cover test associated with horizontal prism at 33 centimeter or as the near target. Yes, the data were analysis by SPSS. Parental, yes, about 81% of the children with the parental history of myopia. This percent is slightly high among female. About 84% of the female have a parental history for myopia. About 76% of male have a parental history of myopia, but the difference was not statistically significant. This highlights the influence of genetic in myopic development. There is a substantial number of the children having inherited conditions from their parent. Correlation between near exophoria and myopic severity, a significant positive correlations was found between near exophoria and spherical equivalence of myopia. This suggests that the children with the greater near exophoria tend to have more severity of myopia, and this highlights the potential influence of binocular vision anomalous on myopic progression. Yes, addressing binocular vision issue could be very important aspect of myopic management. Yes, positive but non-significant correlations between monocular and binocular amplitude of accommodation was found. This finding does not establish a strong correlation, suggests that the accommodation deficit may be, yes, start at the early onset on myopic progressions. Further research is needed to explore the relation between accommodation defect and in myopic development in the early stage. Reductions in amplitude of accommodations effectively due or a lack of accommodations this lead to lack of accommodation, and the lack of accommodations lead to retinal defocus, and this retinal defocus could lead to axial elongations and could be a risk factor for progression of myopia. Yes, the relations between the near point of convergence and myopia, there is the inverse correlations between near point of convergence and myopic severity, but this correlations was not statistically significant. The findings suggest that the potential relationship, but this relationship is not statistically significant. A possible explanation for this lack of significant association between near point of convergence and myopic severity in this study could be due to cross-sectional study. This our study is a cross-sectional study, maybe failed to capture the dynamic relation between near point of convergence and myopic severity over the time. Yes, a clinical implication. The study emphasized that important of assessing Yes, our study emphasizes important for assessing the binocular single vision in myopic child. Yes, detecting and manage binocular vision disorders such as the ecthyphoria could help to slow myopic progressions and enhance visual comfort during the near work. Yes, interventions such as the vision therapy may help to reduce or to elevate the impact of near ecthyphoria on myopic progressions. A regular assessment of phoria and binocular functions are crucial or very important, especially for children involved in prolonged near work. Yes, a very important comprehensive eye examinations for children and an assessment of binocular functions is very important for the child with myopia. And also sometimes if the ecthyphoria is high, and it is good to treat this ecthyphoria by prism or exercise to elevate the impact of ecthyphoria on development of myopia. And also the vision therapy could be very important in reducing the effect of ecthyphoria on the development of myopia. Yes, conclusion. Yes, the study found significant correlations between ecthyphoria and myopic severity in the children suggests that the binocular animals may be contribute to development or contribute in progressions of myopia. However, the accommodations amplitude and near point of convergence does not show significant association between myopic severity. Yes, comprehensive eye examinations for myopic children, assessment of binocular visions to guide effective management of the children, and also further research is needed to investigate the dynamic relation between binocular visions, environmental factor, and myopic development in the children. This is my reference. Thank you.
Thank you, Dr. Allen, for that insightful talk. Now we'll proceed with our panel discussion. Now I would like to call upon Ms. Carla Lanka for the panel discussion, for moderating the panel discussion. Over to you, Ms. Carla.
Thank you so much. Thank you, both of our speakers, for the excellent presentations. I have many questions. I will start with Dr. Allen. So if I understood well, in terms of atropine, you always start first with 0.01%. And then if there is an increase in progression, then you consider other concentrations like 0.15, 0.05. So my question is there any situation, a specific situation, where you consider to start at 0.05%?
Short answer, Carla, is no. Because the 0.01% is so easily available and is available commercially, it's an easy one to start with. I suppose you don't know who's going to respond to the 0.01% until you actually begin. And instinctively, the clinician in me says the lower the dose, the better.
And
Though I have
based
no proof.
yes. And based on your experience, how the patients respond? Do they respond well to this 0.01%, or there are cases where you already know that I know that you want to see the result first and then you move to another concentration, but there are any factors that you identified a priori based on your clinical practice that you know that they may still need higher doses later on?
So I would preface by saying that the vast majority of children we see in Al Jalila are Emirati kids because it's a government hospital, and they seem to respond well to the 0.01%. I can think of a handful of children who haven't responded, and who many have been, of the small number who haven't responded, I think quite a few have been of Southeast Asian ethnicity, sort of Korean, Japanese, so on.
Yes.
So it's always a difficult decision to make. And I'm not quite there about sort of, so you might say, ethnically guided therapeutic decisions, but I think there probably is something in that, and I think I'm sure that the studies like the atom and lamp studies from Southeast Asia, well, they clearly demonstrate that the higher concentrations definitely work better in kids from that part of the world. I'm waiting for more information from other parts of the world, because I suspect that Caucasian patients and sort of Gulf patients probably do well with the lower concentration.
I have another question. How do you deal with syndromic situations? I know that there is still a long way. We don't have many studies, but in clinical practice, do you use myopia control methods in those situations, or not at all?
By syndromic, would you mean sort of like Down syndrome, or you think Marfan's and Sticklers?
Yes, and other genetic situations where we know that there is a high level of myopia progression.
We've really not been offering it routinely to these patients. I'm not sure that there's much information out there on how effective it is or is not. I suspect it's a different mechanism to the regular sort of non-syndromic myopia, but I'm not sure.
Thank you. If we have time, I will do some other questions later on. I would like now like to ask some questions to Dr. Saif on your presentation. So you did not find significant associations between the near point of convergence and the severity of myopia. My question is more related with clinical practice. So I wonder, when you have a patient with myopia, but also with a convergence insufficiency, how do you do your treatment? Which method you start first? Do you treat first the convergence problem or the myopia problem, or how is the protocol in your hospital?
Yeah, I think the management of myopia is complicated. It is better to start with corrections of myopic, like to correct of myopia by the glasses, and after that you need to training like vision therapy to treat convergent insufficiency. Maybe the corrections of convergent insufficiency may reduce some problem in binocularity for the children, as the children spend a lot of time on focusing on the near vision. But here there is a very complicated issue between myopia and, for example, most of myopic have exophoric, and most of exophoric have a slightly far near point of convergence, not near point of convergence. In myopic, near work lead to induce high myopia. For that, the relations between myop and near work and accommodations, convergence, lack of accommodations, this is a very, very, very complicated relationship. It needs a lot of work to understand this mechanism between this.
I have another question. I think this one, maybe both of you can give your impression, because we also don't have a lot of research about the topic. but there are many clinicians around the world using minus lenses to treat intermittent exotropia. And there are some studies showing that those children can have progression of myopia or develop myopia during the treatment course. So I wonder if both of you can give your impression and share your experience with minus lenses if you have.
But yes, I see a lot of clinicians use minus lens for corrections of exophoria or sometimes intermittent exotropia use minus lens, but this minus lens maybe causes a lot of hyperopic defocus, and this hyperopic defocus maybe lead to development of myopia. For that, if any deviation associated with myopia, it is better to correct the exo deviations by exercise. Vision therapy is better than minus lenses. Exercise by vision therapy, like to increase the amount of positive visional reserve. If increase the amount of positive visional reserve, may this reduce the severity of exophoria. It is better for clinicians if any exo with myopia, it is better to do vision therapy better than to give high minus. High minus maybe lead to hyperopic defocus, and this hyperopic defocus could lead to axial elongations and lead to increase the myopia.
Dr. Allen, can you share your experience with us, please?
In the course of my career, I really didn't use over minus lenses very much. I never found them terribly effective. And I certainly haven't done it since, I think there was a PEDIG study, one of the North American studies showed myopic progression in kids who were given over minus lenses. So I don't use them at all.
Thank you so much. I have another question for Dr. Allen. I know that your presentation was focused on atropine, but I wanted to know from the methods that you have available, when do you choose atropine or other methods, or is it atropine your first line of treatment? Please let us know a bit of how your clinical practice with myopia patients evolves.
We don't automatically start treatment until we've demonstrated progression. One of the problems when patients come in the door and they have a prescription, it's even if our refraction shows some increase in their myopia, we're never quite sure how accurate or otherwise the previous prescription might have been. So firstly, we want to demonstrate that there's an increasing degree of myopia. So we almost never start at the first visit. Sometimes do, but generally never. And I think I always have a more general myopia discussion with the child and the family about emphasizing, trying to educate them about what we understand about myopia, trying to reduce unnecessary close work and screen time, especially the sort of phones and iPads and everything that's like very close work or very close distance. I encourage them to try and spend time outdoors in natural light, and discuss the options that are available. So yeah, I tend to take a sort of, I like that, I prefer that we have observed an increasing degree of myopia for starting.
Thank you so much. Dr. Saif, can you also let us know how is the protocol in your hospital, and if you have any first line of treatment, or you choose the treatment based on some factors? Maybe you can let us know how do you do, because it's important for our participants that maybe want to start myopia management to hear different opinions and to know how other hospitals are working on with those patients.
Yeah, thank you for these questions. My practice, I deal with pediatric optometry. Commonly, I will treat pediatric optometry. Most of myopic children until now, commonly we use single vision lens. When sometimes, for me, if any child have any myopic, I give him the optimal corrections for this myopic. I will do a full assessment of binocular vision for this child. If I found the child have any degree, for example, of isosphoria or exophoria, after that I will try to treat this the binocular disorders. If I found any myopic, for example, myopic child have any high degree of exophoria, and this exophoria may have some symptoms, I commonly give the child vision therapy. I commonly give the child vision therapy. I try to increase the positive vision reserve. Most of exophoric child, some of them have less of positive vision reserve. I will try to improve the positive vision reserve. After that, this big issue for the child. Some child not adapt vision therapy. Vision therapy is very difficult. I try with the children vision therapy. If accept that, it's okay. If not accept that, I will give him optimal myopic corrections. I'm not give any child with exotropia overcorrections minus. I'm not recommend any overcorrection minus overcorrections for treatment of any exo deviations. We start to advise the parent about new glasses for myopic control, but until now in the market, until now is not available in our market. But we try to use atropine for control myopia, but unfortunately in our region or in our area, the drug is not available in the market or in the place. This is difficult until now. Also, maybe the optometrists in our regions have a less informations about the protocol to use, like atropine in treatment of or in control of myopia. Until now, there is list of protocol to yes, give step-to-step guideline how to do control of myopia by atropine or something like that. Unfortunately, we read some paper says that if we use atropine 0.01, it's ineffective to control of myopia. A lot of problem. I think this need to be very clear for practitioner to implement the myopic control.
Thank you so much to both of our speakers. We reached the end of our time, and thank you for your participation in this event.
Thank you.
Thank you.
Thank you.
Bye.
The next session is a session by Essilor-Luxottica. Insights on Essilor Stellest lens design, features, and visual performance by Mr. Gabby Steenbeckers. Mr. Gabby Steenbeckers is a global medical advisor in Essilor-Luxottica, Netherlands. Over to you, Mr. Gabby.
Good afternoon, everybody. Is my screen, I'm sharing my screen now. Is it visible for everybody?
Yes, Mr. Gabby, it's visible.
Perfect. Thank you for the introduction. And first of all, thank you for the organization of the Myopia Conclave for this opportunity to talk about the Essilor Stellest design and its visual performance. And thank you for attending this first session of today. We have two within about an hour, 75 minutes from now. We have a second session on the clinical evidence around Essilor Stellest. As I was introduced kindly, I'm Gabi Steenbeckers, a global medical advisor on myopia at Essilor-Luxottica. And this is our disclaimer. So let's go to the spectacle lens with the highly aspherical lensless, the design. In order to design a new generation of myopia control spectacle, the R&D team of EssilorLuxottica has 3 objectives before they start designing this spectacle with highly aspherical lenslets. First, it had to provide sharp image central on the retina. The second objective was to ensure a robust myopia slowdown signal, which follows the shape of the retina. So it's not a surface, but it wants to have a curved shape, so it can follow the shape of this retina. Also, they want to provide a strong myopia slowdown signal, which creates a volume of non-focused light, which follows that shape of the retina. And the third objective was in creating this design of this new generation of myopia control spectacles is to keep the control of the myopia progression effect, whatever the viewing distance and gaze direction is. So let's go deeper into details of the spectacle with the high spherical lenslets. The base of the lens is the correction, and that's done by a single vision zone. The control of the myopia progression is via a highly aspherical lenslet zone, and it has an aspherical geometry, which results in a volume of non-focused light. It's spread over 11 rings, as you can see in the illustration on the left-hand side, and this rings contains contiguous lenslets, and every lenslet has an aspheric geometry. And the lenslets in each zone, in one zone, have the same optical design. And the lenslets in the different rings have different optical designs. It covers about 40% of the lens surface. And the result is that there is a myopia control function active in every gaze direction. So let's go further into detail. The lens provides a myopia correction through a single vision zone, as you can see in this illustration. So it creates a sharp central image on the retina. If we go further into detail on the aspherical lenslets, the lens provides a control of myopia progression through these highly aspherical lenslet zone. And if we then focus on one lenslet, it creates a volume of non-focused light. The light rays through one lenslet you can see here. And this creates a small volume of non-focused light, which we call a micro element. Now, if we consider one light beam passing through one lenslet of this lens geometry of the lenslet, so it enters the eye, and if you look at more light is moving, and then you can see it creates a micro element of volume. So together, when you look at as the 11 rings of contiguous lenslets of these lens, the combination of all these elements create all light beams passing through and creates a volume of non-focused light in front of the retina, and it follows its shape. As Essilor scientists have computed the geometry of the lenslet from each lenslet, the non-focused light follows this shape. On the left-hand side, you see the simplification, but in real life, you can see that it creates a close, complete shell of protection by the highly aspherical lenslet zone. In this 3D image, you can see actually, or this 3D illustration, you can see that this is almost a complete shell. But what's really important is to note that this signal, as it is made of a non-focused light signal, is a stimulus for vision. It only serves as a stopping signal from the retina of the rodent. The lens also provides myopia control, whatever the distance and the gaze direction you're looking at. The surface covered the highly aspherical lenslet zone, and in the end, it has been chosen to maintain the protective effect whatever gaze direction. So it doesn't matter if you look left, right, up, down, it creates this volume of non-focused light in front of the retina and it follows its shapes in combination of a sharp central image. So to conclude, this spectacle with highly aspherical lenslets, so it's a combination between a single vision lens zone and a highly aspherical lens zone. This single vision lens zone creates sharp vision at distance. The highly aspherical zone generates this volume of slowing down signal in front of the retina and follows its shape. And the myopia correction and control of myopia progression are maintained whatever distance and in what gaze direction. So that's about the details of the design. But of course, it's also important to see if there is a quick adaptation and what's the visual performance. So there are many studies done on visual performance and adaptation of Essilor-Stellus lenses. And after 24 months clinical trial, as the adaptation time is very essential in myopia management and for the compliance of the treatment, research with Essilor-Stellus lenses found to be comparable with single vision lenses in terms of adaptation and wearing time. The clinical trial, and I will give you more details in the next session on the clinical trial results, but after 24 months, 90% of children fully adapted within 3 days after wearing Essilor-Stellus lenses. 100% of children, so all the children who were in the study group that were addressed with Essilor-Stellus lenses, were fully adapted after 1 week. And also from a survey with the children, 94% of children felt very comfortable wearing Essilor-Stellus lenses. So that's about adaptation time. If we look at visual performance, many studies have carried out to assess the visual performance of Essilor-Stellus lenses. And in one study, the visual acuity, the near phoria, accommodation lag, and accommodation amplitude were measured after wearing lenses, Essilor-Stellus lenses after 12 months. And it was found that there was no difference in comparison with single vision lenses. We also know when looking through a highly aspherical lenslet zone or HALT on Essilor-Stellus lenses, there was no clinical significance visual performance loss. The third point on visual performance was when looking through this HALT zone of Essilor-Stellus lenses, the peripheral measures of vision, so contrast detection, peripheral global motion processing, and useful field of vision were also unaffected when wearing Essilor-Stellus lenses. A study was presented, the study results were presented at ARVO 24, so May of last year, demonstrated that wearing Essilor-Stellus lenses has no impact on astigmatism, cylindrical power, or corneal astigmatism if you compare it with single vision lenses. So you see that the adaptation time was really quick in the clinical study, and many research that is done on visual performance is that it's very comparable with single vision lenses. So how is it to centrate and fit these lenses in practice? First of all, it's important regarding the frame size that the frame shouldn't be wider than the widest part of the child's face. For centration, you need the reference point and you need the monocular PD or pupillary distance of the right and of course of the left eye. And you need also the monocular height of the left and the right eye. And together it marks the reference point or the centration point. So that's where the center of the rings of the lenslet is. The marking dot is to be used as a reference point as a single vision lens. So many tips on fitting and centration and other tips you can find in the prescriber brochure in our digital booth for you free to download. Please join me at the next session, because today at this session we talked about the design of acellular stellus, but also I'm going to show you the long-term effect and clinical results that's done in the ongoing study on acellular stellus lenses in about an hour. So please join me at this next session at 8:40 p.m. local time. And in the meantime, if you have any questions or you want to have extra details, visit us at our digital booth, where you can download many more information around Stellus. So I want to thank you for your attention. I hope this presentation was helpful to better understanding the design of acellular stellus, and have a wonderful rest of the event, and hope to see you at the second session on the clinical evidence around stellus. Thank you.
Thank you, Mr. Gabby, for the lovely presentation. You can stop sharing your screen.
Yep.
And we'll take you to the next session of the evening.
Everybody, I'd like to open up the next part of the session by introducing Dr. Anupama Rao. Dr. Rao is a consultant ophthalmologist and fellow of the Royal College of Physicians and Surgeons of Glasgow. She's also a member of the European Society of Cataract and Refractive Surgery. Dr. Rao is working with us here at Medcare Eye Center in Dubai. She is active in cases of anterior segment disease, glaucoma, dry eye, keratoconus, and pterygium, and she is also a certified life coach. And Dr. Rao would like to discuss with us myopia workups in pediatric eye care.
Thank you. So good evening, everyone. I would just like to say thank you for inviting me over for this talk. So I do see a lot of children in my practice, and I have really developed a lot of interest in myopia management, and hence I'm here with this presentation. I have no financial disclosures. So the objectives of my presentation for today are to make us all think more proactively about myopia management, especially with early detection and early intervention, to know what the risk factors are to be aware of when we examine children, what are the examinations to perform, and monitoring of progression over time. So I'm sure we've talked from here to the moon about why myopia management is so important and matters so much. And I'm sure there's a lot of talks that will be discussing this. But as we all know, it's of utmost importance in today's day and time. I would say the way we look at managing children now, I think we should look at everyone as a potential myope unless proved otherwise, just going by how important the lifestyle factors have become now and with the kind of lifestyle that our children have. It's best to have a personalized treatment approach because different children will respond differently to the management. And basically, it would consist of a detailed assessment, deciding about what is the best treatment, and then monitoring. So when to start checking is a very important factor. Early detection, we know, provides the best opportunity for effective treatment, and all the associations that deal with the eyes or the pediatrics, strabismus, all these societies are always insisting on early vision screening. So how early is early? So there have been certain guidelines set in for vision screening for children in general. And these are as follows. At birth, every child needs to have a general eye health examination with a red reflex viewing. This could be just a perfunctory exam, not necessarily from an ophthalmologist, but from any of the care providers at the time of birth. Of course, if there's any suspicion, then it gets referred on to a specialist. We then have between a month to 4 years of age, at every routine well-child visit, it is recommended to have a vision screening. As soon as a child is able to be cooperative for a visual acuity check, which could be anywhere between 3 and 4 years of age, one check should be done. In certain cases, we could use further screening such as photo screening or handheld autorefraction if there is a high suspicion, and this could be done electively. Also, all routine school checks need to include vision checks and all the well-child visits done at the pediatricians. So as we can see, we need a lot of support from the pediatric colleagues as well as schools to make it very, very important to have a vision screening for kids. So when the child is finally in the clinic for an exam, as I said, we have to make sure that we're looking at a potential development of myopia because of our lifestyle factors. And then we look at the risk factors, especially the genetic factors would be ethnicity and family history of myopia. As we all know from different studies that these factors are really important. And of course, the environmental or lifestyle factors, which have really come to the forefront now with a range of studies. So the near work, reading habits, screen time, outdoor activities, sleep patterns. I've just made a mention here of parental smoking with a question mark because I came across an interesting study, a few interesting studies that actually tried to find a correlation, although they couldn't really reach a consensus of whether it was helping the progression or worsening the progression. You could have certain questionnaires in the clinic to make sure that you're not missing out on any of the the factors in the history. Here I've just found one which was developed at the University of Houston College of Optometry, which is quite an exhaustive questionnaire. But of course, you could just have one of your own that works well for your clinic. So the evidence for how important it is to ask for the history of all these factors. I know there will be other talks or have been other talks that have spoken about this in detail, but I'm just going to go over it for the information. So there have been many studies where the environmental factor risks have been reviewed. And I would say that this is one of the studies where a lot of factors were assessed, and the strong and causal factors were found to be time, outdoors, and education, and also parental myopia.
You can try sharing your screen again, ma'am.
Yeah, I think it was some hold up. Okay, I think now it's moving. Okay, so there are a lot of studies showing the association between near work and myopia, outdoor activity myopia, seasonal variations, and like I mentioned about the smoking and myopia. So when we start the examination, of course, we do a routine set of examination for all the children who come in, but we might have to add in a few other things now in view of the myopia issue. So visual acuity testing, refraction and cycloplegic refraction, this is quite standard, but I really have to emphasize on the cycloplegic refraction because I have come across situations where children have been prescribed glasses without a cycloplegic refraction. So I would say the standard of care is cycloplegic refraction in kids. Of course, we are doing autoref keratometry. It's very important to maintain accuracy and consistency of the tests that we are doing. Also, binocular vision, accommodation and convergence, because we know that binocular vision dysfunctions are also risk factors for myopia progression. We would do a detailed anterior segment examination on slit lamp, both undilated and dilated, based on the cooperation level of the child.
Dr. Anupama, can you just switch off, close the presentation and just try to reopen?
Yeah, I guess, because something is really not working. Okay, let me share again. Just hold on a minute because I can't seem to find it now. It's not showing in my. Are you able to see it now?
Yes, doctor. We are able to see now.
Let's just move on to wherever we were and see if it is
Yeah,
working.
you can just press on the play.
Yeah, let me see if it's working with Okay, is it okay now? Are you able to see it?
Perfect, perfect.
Okay. I really have to rush through it now. A lot of time has passed. Anyway, so we will do an anti-segment assessment as feasible based on the age and the cooperation of the child. And of course, fundus evaluation to rule out other pathologies. Here, I need to say a word about a group of kids that we are now defining as pre-myopes, because it has been found by different studies that there's a very important risk factor where there's a measurement of 0.75 at age 6, 0.5 at 7 to 8, and 0.25 or less of hyperopia. And they seem to be having a higher risk of progressing, and they are defined as pre-myopes. The reason I mentioned it here is because we are speaking about the refraction of the children. The special test that we would also want to do from the point of view of myopia detection and progression would be a biometry or any other form of axial length measurements, because there's been a lot of evidence that it's very useful in predicting the risk in progression. And of course, we need to do it at baseline and at every visit. We also have to do a corneal topography because, again, there's a correlation between the axial length and corneal radius ratio, and also correlation with sphericity of the cornea. Also, for those practitioners who are intending to do contact lenses for the children for slowing down the progression, the topography is a very important tool. I'm also mentioning here about OCT for choroidal thickness. Again, this may not be something that people are doing as a standard, but since we have a lot of evidence correlating choroidal thickness to the myopia progression, this may be also a useful test to do. So here's the evidence for why we need to do all these tests. We all know the importance of axial length. So we need to know if the child is having more than a physiological increase in the axial length, which is when we would start to think that there is a progression of the myopia. And I'm sure all these values are quite well known and easily available. In the interest of time, I'm just going to be moving forward. There's also a lot of data there about predicting myopia and myopia progression using ALCR ratio, which is why doing a topography would give us a lot of information. The way I do it in my clinic is that I like to give parents of all the children enough information about the risk of myopia in childhood age groups. So I have a information page that I share with all the parents that talks about the condition and its risk and about the management options. Also, very important to discuss goals of treatment, because if the patients drop out of their follow-up, then we're going to lose track. And a lot of times you see kids coming much later and then they've had a big progression. So the short-term goals of reducing the frequency of prescriptions and maintaining good vision, as well as reducing the risk of diseases in the future. We have to emphasize regular follow-ups. Like I said, if they're lost to follow-up, it's very hard to keep track of what happened. Also, I talk about rebound effects of stopping interventions once we have discussed what intervention we are going to use. I also suggest examination of the siblings because a lot of time the family comes as a whole and then one child has been diagnosed. It's always useful to tell the parents that, let's check your other child also. I also emphasize the importance of managing lifestyle factors and sleep. As far as lifestyle factor management counseling goes, we have to talk about increased outdoor time, especially in this part of the world where in certain months it's hard for the children to be outdoor, but we can find different ways of doing it. So there have been suggestions of doing the lessons outside, doing any outdoor activity in school, or even the family taking weekend outdoor trips. Also, we all know about the screen time, the 20-20-20 rule, maintaining a good posture and reducing the eye strain. So there are a lot of tools out there for monitoring progression. I'm sure there's a more detailed talk on this coming up. But there are some cool machines there. If it's possible to have them, then they can give us a lot of data about how the progression, and some of them are very easy to explain to the parents because they show trends and red and colors, so you can explain to the parents how the child is progressing. So it's very important to integrate myopia management into a practice. If you do see a lot of children, it's very important for all the staff to be on the same page. Everyone needs to be focusing on what is necessary for the detection and the management of myopia. Like I said, having the information resources, having the equipment, and maintaining a good protocol for follow-up and monitoring. There is a lot of information about future possibilities in myopia management, a lot of emerging technologies, and public health integration, I think, is a very important thing. Like I said, we need support from the schools. It should be mandatory for all the kids to be checked at regular intervals, and also from our colleagues in pediatrics. So the take-home message from me would be early testing of children is very important. We need to assess the risk factors in all children. Detailed history is very important. It's good to maintain a standard protocol for examination so we're not missing out on any of the data. Remember to monitor the pre-myopes, as I mentioned. If there is a high risk of progression based on the risk factors and the rate of increase of the axial length and such, then a close monitoring is required. I usually see the high-risk kids sometimes even every 3 months, but as a standard, once in every 6 months. We need to have standardize our methods of monitoring the progression in our own practice. Very important to get parents on board with educational tools so they know what is the risk of progression, and also they are the ones along with the educators who can emphasize the control of lifestyle factors. So here are my references, and thank you very much for your attention.
Thanks so much, Dr. Anupama. There's some great advice there, which I'm sure we can all use in practice. So our next speaker is Dr. Syed Ali. He's a consultant pediatric ophthalmologist at Moorfields Eye Hospital in Abu Dhabi. after spending 13 years in the NHS in Durham and Wolverhampton. He specialized in the treatment of pediatric cases such as congenital cataract, congenital glaucoma, eye trauma in children, and ROP, and treats all forms of strabismus in children and adults. Dr. Syed would like to discuss with us the evidence-based role of low-dose atropine in myopia control.
Thank you for inviting me to talk about evidence-based role on low concentration atropine in myopia management. And yeah, as you said, I work at Moorfield Eye Hospital, Abu Dhabi. So I'll review some studies about clinical efficacy and safety of atropine use and our local guidelines and audit from Moorfield. So I'll start by a consensus statement from World Society of Pediatric Ophthalmology and Strabismus. And myopia is the commonest human eye disorder. And the economic cost of myopia is more than $250 billion annually worldwide. And now we have found that there's a good genetic association with myopia. More than 20 loci has been identified. And according to World Society of Pediatric Ophthalmology, the interventions which works for myopia control include behavioral interventions, optical treatments, pharmacological treatment, include atropine eye drops. Atropine is a muscarinic antagonist and traditionally used for cycloplegic refraction, in inflammation. In amblyopia treatment, we use 1% for atropine penalization. So when we call low strength, a low concentration atropine, it means ranging from 0.1% to 0.01%, which is emerging to be safe, effective option in myopia control. The exact mechanism is unknown, but it works through muscarinic receptor in the retina or via remodeling of fibroblast. So it modulates the scleral fibroblast activity to promote choroidal thickening. And it has been demonstrated that thickening of choroid with atropine also shows in the same patients slowing of myopia progression. So evidence by studies. So atropine in early 2000, there was a landmark study in Singapore, which was randomized, double-blind, placebo-controlled trial. 400 children were included, ages from 6 to 12, and refractive error between -1 to -6 diopters. So there were two groups, the treatment group and control group. So treatment group received atropine 1% only in one eye at night for 2 years. And the second eye also works as a control. And the side effects were noticed, like photophobia, blurred vision, allergic reactions. In the study, they noticed it slows the progression of myopia by spherical equivalent about 77%, and axial length about 75%. And there were side effects which were like blurriness of vision and photophobia. And there was also noticed a rebound of faster myopia progression after stopping the treatment. This follow-on study was ATOM-2 study, and it was used low-strength atropine. And it was again randomized, double-blind, placebo-controlled trial with 400 children, 6 to 12 years of age, with this myopia ranging from -2 to -6. And it uses 3 different strengths of atropine, 0.5, 0.1, and 0.01%. So it also has a follow-on phase, which is washout effect, to check for any rebound myopia. So in conclusion, this study was effective, safe, and well tolerated with 50% reduction in myopia by using 0.01%. The LAMP study, which is low-dose atropine and management of myopia. It's a multi-center randomized double-blind placebo-controlled trial from Hong Kong. which has 438 children, 4 to 12 years of age, -1 to -6 diopter myopia. It has got 4 groups using very low strength atropine 0.05%, 0.025, and 0.01% in a placebo group. These studies, the drops are put in both eyes. So the study proves that it reduces myopia progression, and the most effective concentration was 0.05%, but 0.025% offered more favorable balance between efficacy and safety. So this is an interesting graph, which is showing like the bottom line here is showing the natural progression of myopia, which was reduced for 2 years of atropine use. But if you see over here, the 1% group from ATOM 1 study show greater rebound after stopping the atropine. In this group, 0.01% had the least rebound myopia after stopping the treatment. There's another study from 2023 in JAMA Ophthalmology, which says that 0.01% drops compared to placebo is not slowing down the progression of myopia. So it says that it's not effective. So the population was different because it's from American population, which was different by race or ethnicity. And there are also like racial differences may have a different response with atropine. Another factor, the control group in ATOM study, over 2 years, there was a natural progression of -1.2 diopter myopia compared to, in this study, the placebo group, there was only progression of 0.07 over 2 years. And this is another table comparing different strengths of atropine used. But here, if you see LAMP study and ATOM 2 study, the effectiveness of myopia progression control is very similar, like minus 0.55% and diopter and minus 0.49 diopter, similar with the axial length. So going to our local guidelines, we try to include all children myopia into our myopia management, excluding only secondary causes of myopia. The younger the children who are less than 10 years with the East Asian ethnicity and parents are myopic are associated with fastest progression. And these are the children gain the most with myopia management. So in our assessment, we check the risk factor, the age, the ethnicity, the parental myopia, near work, visual environment, and time outdoor. Then refraction with best corrected vision, ocular health assessment with full fundoscopy and corneal exam, and axial length. So we look for secondary causes, like if it's a high myopia and under 10 years of age, or if it's myopia greater than the year of children age in diopters, or associated with reduced best corrected vision, nystagmus, night vision problem, the abnormal macular OCT, clinical features of retinal dystrophies, any familial history of visual impairment or hearing loss. So there was an audit performed in Moorfield, Dubai, with approximately 180 patients, 360 eyes, range from 6 years to 16 years, which have a previous progressive myopia of more than half diopter per year. Our treatment pathway was the baseline refraction with optometrists, provide full information leaflet to parents, and then ophthalmologist consultation with the axial length measurement. And 1 month after the starting atropine, the optometrist gave the call to the parents, and then 6 months later, there was a repeat refraction. And 12 months we repeat the axial length and the cycle started again for the second year. This is a leaflet we give for low strength atropine. When optometrists call from myopia control after 1 month of treatment, they're mainly looking for the compliance and any side effects or any concerns by the parents. So we check for like a previous and refraction and after treatment, before and after. So there is like a average yearly progression. So you can compare like this is average yearly progression in spherical equivalent compared to after treatment. So there was good response. So overall, 92% have shown reduction in progression with treatment. 42% of our patients have no progression. And the higher level of progression prior to treatment is the patient who have the most effective with the myopia management with the low dose atropine. So we need, we're doing a further audit with age, ethnicity, and axial length changes. So in this protocol, if in 6 months, if the treatment was not effective, we consider stopping or adding a treatment with a different modality of myopia management. So normally, if it's effective, the treatment lasts for at least 2 years. And if at end of 2 years it's stable with progression less than half diopter myopia, we consider stopping the treatment. After stopping the treatment, we review in 6 months to see any post-operative rebound myopia. So in conclusion, the low concentration atropine has proven to be a promising treatment for control of myopia progression. It offers a relatively safe and effective alternative to more aggressive invasive treatments. 0.01% is effective and has far less side effects, and it is the most commonest stent used worldwide. So these are my references. And acknowledgement to Dr. Manjave providing some of slides, and Dr. Drikshandapuram provided me the audit from the field. Thank you.
Thanks so much for your presentation, Dr. Said. We really appreciate you contributing to today. So our third speaker is Yeshwant Saoji. Yeshwant is a very experienced optometrist and director of Saoji Vision Care, which he has run for more than 20 years in Nagpur in India. He specializes in pediatric cases and fitting complex contact lenses, such as a scleral lens fitting I saw recently on LinkedIn in the case of a child with corneal trauma, which was caused by a broken spectacle lens while playing ball sports. Yeshwant will be advising us on setting up an ideal myopia control practice. Thank you.
You need to double click to enter the full screen mode, I believe. That's the message displayed. Yep, we can see now.
You can see now? Okay.
Yep.
Great. So amazing conference. Thank you all for the invitation. And let's straight away dive into a very important topic. A few tips I would like to share in starting a myopia control practice. Now, as the age progresses, we all go to physicians for a routine checkup so that diagnosis can be done timely to prevent future complications. Similarly, for myopia, which actually progresses because of the hyperopic defocus, if we take timely steps and avoid excessive elongation of the axial length, then it can prevent future problems at the back part of the eye. We all know higher the myopia, longer is the axial length most often when it's an axial myopia, and more susceptible are the eyes for complications later in life. So it's very, very important. And I think all of us, whether ophthalmologists or optometrists, all of us are convinced about stopping this myopic progression or slowing it down because we can't really stop it. But then why everybody is not diving into starting a myopia practice? And personally, I feel the challenges could be lack of complete clarity in how to manage a patient. Some people feel that setup initially is quite expensive, and skills definitely need to be upgraded because it's slightly different, although not too different. A few tips that I would like to share is learn the options of myopia control And honestly, sometimes we make fun of the WhatsApp and Facebook universities, but there is so much of knowledge there. If you read the right content, then you get so much of knowledge, when to use what method, when to use the combination therapies, brush up about the knowledge of ortho-K and the fitting knowledge of RGP contact lenses, understanding the fluorescein patterns so you can perform better when fitting ortho-K lenses, and understanding various spectacle designs and when to prescribe what and how are the results of each spectacle-based myopia management treatment. So how we started is we initially started counseling all the myopic kids coming into our clinics, and we just talked about complications of myopia, and unfortunately we did not get success there because the patients used to say, we'll think about it, and nobody ever came back. Then we realized we had an A scan. We started doing axial measurement on an A scan for every patient. So A scan is a fantastic screening tool. It may not be a proper follow-up tool, but when the patients saw the graph going up on the A scans, they realized, okay, this kid's axial length is longer and the kid needs to be monitored properly. So for the high-risk patients, we had tied up with an ophthalmologist, and we used to send these patients for optical biometry and follow these cases. So the result was more parents got convinced about myopia management, and it helped us to dispense myopia control spectacles and ortho-K lenses. The target we all know is axial length has to be below 26 because there's something dangerous about crossing 26. And please keep in mind, this 26 is when the child becomes a grown adult and the myopia stops progressing. So don't think that a kid has 25 millimeters of axial length and the kid is safe. No, you have to calculate and predict if this kid is likely to cross 26 millimeters of axial length. And if the kid is likely to, then you need to initiate myopia management program. Have collaboration with ophthalmology clinics or any optometry clinics who have an optical biometer. They generate beautiful growth curves, and whether the myopia management program is indeed working or not. It's very easy for the parents to understand, as the speaker before this told us about the color coding. So red means it's not getting controlled, yellow means it's getting controlled, but not to an extent that we would like it to be, and green means a good control. Spend some time counseling these patients with these reports. So when you have something in your hand, then the patients are easily convinced about it. Until you have access to this, you can simply put this data in an Excel file and generate the curves yourself, and you can predict whether this kid is likely to cross 26 or not. So when the patient sees these Excels, then it's very easy for them to follow up and do all these tests, the binocular vision examination. I think we have a talk about BV in myopia clinic. It's an integral part of any myopia clinic. Recommendations definitely need to be given. Reduce your near work, increase your outdoor play to 90 minutes per day in open spaces, less clutter of your study room, and all these standard recommendations, you should have it in printed format and give it to all patients so that they can follow it religiously. As I said, myopia management is not too different from your routine optometric practice, but a bit different because you have to be thorough in your examination. So we devised a very stringent protocol for every myopia patient, and we do a 1.5 hours of examination for every kid who walks into our clinic for myopia control. So when the examination is very comprehensive, it is likely that the patients would follow it up very religiously. Few numbers to remember. Average axial length growth is 0.1 millimeter per year. 26 millimeters in the late childhood or early adulthood is the danger mark. And early onset myopes progress faster. Even one diopter of myopia is risky, according to Dr. Flitcroft, who is a pediatric ophthalmologist. And it's the progressive axial myope who needs to be put on myopia management program. So these things initially may look a little complicated, but once you get the hang of it, it becomes your second nature. And this is how my present clinic looks like. So we started with only counseling the patients and directing the patients to proper myopia practices until we have a state-of-the-art facility in our clinic itself. Guest speakers make a huge difference. So rather than we telling our patients, if we invite a guest speaker and have a gathering of maybe 100, 150 potential patients, the guest speakers can actually impress better than your local ones. So we had an experiment done with Dr. Barot, who is a expert orthokeratologist from UK, and it was a phenomenal success. First day itself, we booked so many myopia management patients, and we put almost about 5 patients on ortho that particular day. LASIK clinic, many optometrists feel that LASIK is a competitor for ortho-K. It's not. Actually, we can have a symbiotic relationship. We can control the myopia progression. And if the myopia progression is controlled very well, the ophthalmologist can zap this patient later on. So it's a symbiotic relationship. You just need to sit with the ophthalmologist and convince them. So this was my dream, which I had actually posted on my vision board. I wanted to have a clinic like this, wherein the patient can lie down for ortho-K and hear the success stories of myopia management program and get convinced about wearing ortho-K. And this is what we have today. So we have 2 beds. And in case if you're not able to read what's written on the bed, it says sleep on this bed to get rid of your glasses. So it becomes a talking point for myopia management program. And we have a global fee for 1 year. We manage your myopia and we charge 7,500 Indian rupees. And that actually helps us to get the patients back for regular follow-up. We eventually upgraded to an excellent corneal topographer, which is contact lens-based corneal topographer, and an optical biometer with an iSuite myopia software. So now it becomes more easy for us to counsel the patients. So these are the wonderful maps and growth curves generated by the instrument. And we have a lot of softwares in the clinic which we use to design the custom designed orthokeratology lenses, which actually enhance the myopia control. And it's very impressive on and all. So patients are very with our treatment. So initially, you may not want to invest so much into having a complete trial set of ortho-K lenses. Start slow, but eventually aim to get there. So today we have about 750 lenses right in stock in the clinic. Charge fees. That's very important. In India, many people give their services free of cost. It's not valued. Charge fees and charge higher. It becomes more convincing and more effective. So 3 takeaways from the presentation. We can start myopia management in the existing setup and eventually and gradually upgrade to the most ideal setup. Myopia is on the rise, so there is an increased demand for myopia clinics in the country. And do a 6 to 12 months internship or an externship with an ideal myopia center to get adequate exposure, and then aim to start your own. So these are few pictures. This is one picture wherein we had invited about 150 potential patients, and that's Dr. Nitesh Barot giving a talk on orthokeratology. And on your right is the orthokeratology fit. I know it doesn't look exact like the ortho-K because this is an hyperopic ortho-K. I just put it out of interest. So I hope some of these tips would inspire people who are thinking of starting a myopia management practice to actually start one. That's all from my side. Thank you very much. And I think I have finished bang on time.
Yes, thanks, Dr. Salji. It's a very nice presentation. Very often in business, I'm hearing about how valuable it is to engage with influencers. So people that are already on social media. It's a very valuable thing, and it's quite easy to ride on their coattails if they've already got tens of thousands or hundreds of thousands of subscribers. So that it's usually quite a shrewd business move.
Sure.
Now, I was wondering in your presentation, when you're doing the graphs of the axial length, which interval do you find to be most helpful? Because measuring the axial length is very accurate. In fact, we have the same lens star in SKMC, and so it's accurate to 100th of a millimeter, I believe. So if you're doing the axial length measurement, if you do it too often, does it throw up spurious data, and it's better to do it only every several months? Or how often do you find?
Yeah, we do it once in 6 months, and it's the K-Max scale, which is very effective in convincing the patients.
K-Max.
Very easy to understand.
So you also discuss the topography with them?
No, topography is done only if we think of doing an ortho-K fit, not for every patient.
Right. And what range of myopia do you find that the ortho-K is effective for?
We generally don't tend to go over -6 diopters. And if at all we do have a myop which is beyond -6, then we prefer to give partial ortho-K, which is shown to be equally effective as full ortho-K.
And usually in which age? Because if a patient is -6, but yet they are still young, you know, we've had patients with even like scripts of -7, but around sort of 10 years of age. So is that too young for ortho-K? And certainly not that range of prescription, but if let's say they're -4 at the age of 10, would they be a good candidate for ortho-K?
Yes. My youngest patient is 6 years old.
Ooh.
So depending on the progression, if the kid is at a high risk, like if the parents are myopes and the kid is progressing fast, we might prefer to straight away jump on to ortho-K, or we might even prefer spectacle-based myopia control till the kid becomes more responsible and then switch the patient to ortho-K, or sometimes we prefer to just keep a watch.
And are you finding there's a good uptake of myopia controlled spectacle lenses in your clinic?
Yes. It's more easily accepted by parents. Totally non-invasive.
Yeah, we get the same thing actually for low vision aids. That people they come and they still expect to be able to improve their vision. You know, Stargardt's patients, they say, please, you know, find some glasses which will help. So it's still, people associate still whatever the condition of their eyes and whatever the potential, they still hope for some glasses which will help. So it's good to have that option at least. And atropine as well has there been a reasonable uptake in patients using atropine and the parents accept it?
No, it generally works this way. Unfortunately, in India, the ophthalmologists prescribe atropine and the optometrists go in with the optical strategies. So sometimes there can be a cross-referral. So if I feel that the patient needs to be on atropine as well as ortho-K, I do my ortho-K fits and refer the patient to an ophthalmologist for taking care of the atropine prescription.
Yes. And it's available for dispensing from the clinic, or it has to be prescribed by a physician?
No, it has to be prescribed by an ophthalmologist. Optometrists are not allowed to prescribe atropine.
Because Dr. Said Ali, in the UAE, it's still the case that it has to be formulated and prescribed.
Commercial preparations are available now. So in many pharmacies in Dubai and Abu Dhabi. If it's other than 0.01%, I normally send to Cleveland Clinic for formulation. So they can make it even 0.02% or 0.05%.
We know this is effective as per your presentation. Thank you.
Thank you.
Yeah, that was a fantastic presentation by all the most experienced speakers. My question to Dr. Anupama and Dr. Said Ali, what's your take on advising a low-dose atropine for an immetropic child with or without family history of myopia?
Dr. Said, you want to take that one first?
Yeah. So like if it's there's no family history and it's a low myopia, normally first 6 months I do a recheck for seeing any progression. So in case there's no progression, no family history, then we'll withhold. But it's again, even a drops is a commitment. But optical correction, I can, from the start on first visit, normally I suggest. But for atropine, normally if I see a progression of 6 months, then normally starts atropine. But from the start, if the parents are very high myopic and the first prescription is already like minus 250 or 3, then maybe from the start.
No, I'm asking about the immetropic child.
Emmetropic, no, sorry, I get the question wrong. So emmetropic child, like pre-myopia, yeah, I know there are a few studies, but no, I'm not giving any atropine for pre-myopic patient or emmetropic child. No drops.
Yeah, I would agree with that. I think I would just focus more on maybe closely monitoring them if we think they have more risk factors. because after all, it's an intervention, so it may not also be well received in the sense of if the child doesn't even have a refractive error as yet. So I would do that. I would just monitor first.
Thank you, Dr. Anupama, and thanks for highlighting the importance of measuring the choroidal thickness. I mean, which many practitioners don't highlight on that. I mean, that's very important in monitoring the myopic progression. And Yashwant, that was a beautiful presentation from your side, and it was a beautiful way of explaining the graph using a simple Excel sheet.
Yeah.
That's very good. And my question to you, as an orthokeratologist, in terms of fitting ortho-K lenses using a trial set versus a topograph-based ortho-K lenses? Can you just tell me the percentage?
See, I'm tempted to say that the customized Ortho-K are far better than the ready stock Ortho-K. But to be very honest and fair to the ready stock Ortho-K lenses, I would try a ready stock first because you actually get to see the fluorescing pattern. And if that fits, and if you have the treatment zone falling inside the pupillary area, then you know the control is going to be good. So have a look at two aspects. One, the treatment zone has to be inside the pupillary area, and the treatment zone should be at least of +4 diopters. So let's say if the child is -5, then I might prescribe a ready stock Ortho-K provided the treatment zone is inside the pupillary area. But for PARs below -4, I would prefer to custom design because we know for every diopter of myopia corrected, you get a +1. So let's say you have a myop of -2, then you only get a ring of +2, which is not going to be sufficient. So you order a custom design lens wherein you increase the plus bar in the treatment zone, not the treatment zone, the reverse zone.
That's fantastic. Thank you very much.
Could I ask a question of Dr. Ali, please? Because I saw from your slides that about, when do you decide to stop the atropine? Because we do hear a lot of pediatric ophthalmologists saying that, you have to counsel that it's a long time, till a certain point where you know that, they've crossed a certain age where it's not likely to progress or there are different schools of thought. So you said 2 years, right? That you have.
So initially, when we're giving the treatment, we advise them that it will be at least for 2 years. It can be longer as well. And then sometime, after stopping, if there's a rebound effect, we will start again. So there are now studies with a 5-year outcome LAMP study, follow-on studies published last year with 5 years. And then there's also some published study of even 10 years. But in our practice, like 2 years, then a gap, if there's still progression, we can restart. But yeah, so we convince them it's a commitment at the start, like it will be at least for 2 years. And
so when you stop, sorry, go ahead.
Yeah. So, and then combination, so I don't start together, even if in the progression in last 1 year, if it's severe progression, even then, 2 modalities I don't start. I start like either atropine or optical correction. And then 6 months later can be combined as well. Thank you.
So when you stop, how soon do you check them for the rebound?
Yes, 6 months.
6 months. Thank you.
Dr. Ali, sorry, I have one final question. Now, the rebound effect with low dose atropine versus higher dose atropine, like for example, 0.01% versus 0.05%, which one has got the higher rebound effect?
Yeah, so the lowest is with 0.01%. Yeah. And the highest was recorded with atom 1 was with 1%. But that 0.05% and 0.01% is slightly different. But the least rebound effect is with 0.01%.
So do you guys have spectacle-based myopia control available in Abu Dhabi, in UAE?
Please say it again.
Do you have the spectacle-based myopia control options available in the United Arab Emirates?
Yeah, we do. We do.
Yeah, we do.
So have you any time prescribed a spectacle-based myopia control along with atropine to the patient?
Not from the start, but like combined later on. Like if it's one is less effective, so we're giving like a spectacle-based myopia control. 6 months or 1 year later, that we see that it's not satisfactorily controlled, we can add on drops.
Okay.
For me,
Thanks
as
very
a
much,
routine practice,
everybody.
like whenever I dispense the myopia control spectacles, I send the patient back to the ophthalmologist, asking to prescribe the low dose atropine as a combination therapy. I mean, it's working. It's giving very good results. Combination therapy is giving a very good result.
We'll get some new data actually, because Gabby Steenbeck's coming back in a moment. He's going to give us some trial data on EssilorLuxottica's Stellus lenses. So we're going to hand over back to him.
Thank you very much.
Everybody. It's a very stimulating conversation. We could carry on for hours, I'm sure.
Thank you.
Thank you.
Thank you.
Thank you.
Next is a session by EssilorLuxottica, Essilor Stellus Lens Latest Clinical Evidence by Mr. Gabby Steenbeckers. Mr. Gabby Steenbeckers is a global medical advisor at EssilorLuxottica in Netherlands. Over to you, Mr. Gabby.
Thank you again for the kind introduction and the organization of the Myopia Conclave. To have this opportunity to talk about the clinical trial in regard to the Essilor Stellus lens, and we'll share with you the latest evidence on the clinical trial. As I was introduced already, hopefully my screen is moving. Is my screen moving? I assume it is, if I didn't hear anything. So this is the disclaimer. For the people who are attending this session and didn't made it to the first session we did on the design of Essilor Stellus, you can see here in a small summary that the lens is a buildup of a correction zone based on a single vision and control of myopia progression with the highly aspherical lenslet zone. And this results in a volume of non-focused light, which created by the 11 rings integrated in this lens. And every lenslet has an aspherical geometry. The lenslet in one ring has the same optical design. Oh, I think something went wrong. And the lenslets in the different rings have a different optical design. This results in this volume of slowing down signal in front of the retina and follows its shape. So the highly aspherical lenslet zone covers about 40% of the lens surface, and it results is that it creates a myopia control progression function in all gaze directions. So let's go to the clinical study that's done. We're running now in the 6 years to be exact, and I will share with you until the 5 years result. So it started all in 2018 in Wenzhou, China. It's a prospective randomized double mask 2-year clinical trial when they started. As you can see on the slide, they recruited or included children of the age of 8 to 13, did have normal vision and no history of any myopia control treatment of any kind. So there were 2 arms. One study group were addressed with Essilor Stellus lenses, and the control group was addressed with single vision lenses. They visited and they were randomized to each arm, and they visited every 6 months for the checkup. So the key results after 2 years for all subjects were 0.8 diopters in myopia progression and 0.35 millimeters in axial elongation on average for all subjects. But they also looked at children who wore Essilor Stellus lenses for as full time, which means that they wore the lens, the spectacle for more than at least 12 hours per day, every day. And what you saw is that the result was that the efficacy increases by 60 from 0.8 diopters to almost 1 diopter on average. So to be precise, 0.99. And if you look at the actual elongation, it was increased from 51% up to 60%, or an equivalent of 0.41 millimeters on average. So as I showed in my first presentation, the adaptation was really quick. 100% of the children fully adapted within 1 week. But what also was found after the first and the second year of the clinical trial, that the eye growth of 9 out of 10 children wearing Essilor-Stellus full-time, so 12 hours a day, every day, were similar or slower than non-myopic children. So making a leap to the 4th and 5th year, I will give you the, before I will show you these results, I will share with you verbally the results after 3 years. After 3 years of the clinical trial, the total decrease in myopia progression was more than 1 diopter, to be precise 1.06 diopters, and also a cumulative decrease of 0.49 millimeters in actual elongation after 3 years of using Essilor-Stellus lenses in comparison with the combined single vision lens control group. What was also found that Essilor-Stellus lenses slow down myopia and actual elongation in older children, as the children were 10 to 15 years of age when they were transferred into the Essilor-Stellus group. So here you can see the extension from year 2 to 3, as previously described, into year 4 and 5. 44 children started and in year 4, and at the end of year 5, 43 children completed the 4th and 5th year of the clinical trial. Year 4 and 5 of the clinical trial didn't have any control group. This like in the year 3 and in the first 2 years, we have a physical control group with single vision wearers. And this was because of ethical reasons. Instead of the real-life single vision control group, there was an extrapolated control group was used in year 4 and 5. And this extrapolated control group was based on the model proposed by Champ et al., in which means actual elongation decreases as age increases by 50% per year. And there was a model proposed by Soderman et al., in which the spherical equivalent decreases by 9.7% per year on average. And these models were applied to the initial control group that participated in the 2-year randomized controlled trial. And it was found that the myopia progression and actual elongation in the extrapolated control group was very comparable to the actual change of actual elongation of the spherical equivalent refraction during the 3rd year with these real-life recruited age-matched controls. Thus, Champ et al. And Soderman et al. Models were validated by comparing against the year 3 single vision control. So these models proposed by Champ and Soderman and their colleagues could be a valid option for avoiding a placebo control group if there is prior information on actual elongation. As you can see on this slide, after the 5 years, on average, Essilor-Stellus lenses slowed myopia progression by 1.7 diopter on average for all subjects over 5 years. And this was in comparison with the extrapolated control group. So this shows that the efficacy was sustained over 5 years period. If we look at the actual elongation, Essilor-Stellus lenses slowed actual elongation by 0.72 millimeters on average for
all subjects over 5 years, also in comparison with the extrapolated control group, as you can see on the left-hand side in the graph. So also this after 5 years, the sustained efficacy of the actual elongation is shown. For these results, we can see that children wearing acilar stellus lenses over 5 years, the mean progression was 1.72 diopters. Another way to interpret these results is to consider how long it took the untreated control group to progress by these numbers. And the answer is less than 2 years. Therefore, it can be stated that acilar stellus lenses save 3 years of myopia progression and actual elongation. These results of the 5 years clinical trial were just published in a peer-reviewed article, Eye and Vision Journal. And hopefully soon we will be sharing new information about the 6 years result as this is now analyzed. So to conclude, acilar stellus lenses slow down myopia progression by 67% on average. Also, over a 5-year period, the slowing down myopia progression was 175 diopters and the actual elongation by 0.72 millimeters on average over these 5 years. Acilar stellus lenses efficacy is in slowing myopia progression and actual elongation was sustained in older children up to 18 years of age. So going forward, there was also another study conducted, which was a randomized double-masked crossover clinical trial with acilar stellus lenses to see if there is any data suggestive of any rebound. This was this study was executed in Vietnam for 1 year, and the inclusion criteria were kids from 7 to 13 years of age. Also, as in the 2-year randomized control trial, they had no history of myopia control. The myopia prescription was between 0.75 and 4.75, and they had normal vision. So almost 119 Vietnamese kids were in the acilar stellus study group or in the single vision group. Half of them started with acilar stellus lenses and the other half started with the single vision lens as a control group. And over 6 months, they were transferred into the other modality. So they were crossed over. The key results was that the efficacy, the randomized double-mask crossover trial demonstrated that acilar stellus lenses slowed down the myopia progression in myopic children. And one of the other objectives was to see if there is a rebound effect once stopped with the treatment of with acilar stellus lenses. And the data was not suggestive of rebound in myopia progression with patients that were switched from acilar stellus lenses into single vision lenses. All these publications that were connected with the clinical trial or the crossover trial, you can find here. But there are many, many, many more peer-reviewed articles on acilar stellus lenses. So please visit our digital booth where you can find the full research publication leaflet where there are many more peer-reviewed articles for you to read. So to finalize this presentation, I want to also give you some highlights or some update on the clinical trial that is done in Europe. It's a multi-center European prospective interventional study with a single group assignment. And the investigator sites are in Dublin, Ireland, in Rotterdam, the Netherlands, and in Paris. And the duration of the study, which is called SLOAMS, is 24 months. And it is to evaluate the efficacy, the acceptability, and the quality of life implications of acilar stellus lenses in slowing down myopia progression in European children aged between 6 and 16 years at the time of inclusion. And we are now 1 year on the way because the recruitment started in March 24. And the primary endpoint is to see what is the change in axial elongation and cycloplegic autorefractor from baseline to 24 months compared to the expected change based on axial length and refraction centile positions at baseline. I want to thank you very much for your attention. Have a wonderful rest of the event. And if you want more details, don't forget to visit us at our EssilorLuxottica digital booth, where you can find, for instance, the publications on Essilor Stellest and more leaflets for prescribers. Thank you.
Good evening, delegates. It is with pleasure that I introduce to you Dr. Rizwana Hussanuddin. Rizwana will be known to many of you as Program Director and Associate Professor of Optometry at Gulf Medical University. You may not know she is also President of the India chapter of the American Academy of Optometry. Dr. Hussanuddin will be speaking tonight on the role of binocular vision in myopia. Welcome, Doctor.
Okay, once again, welcoming all of you to the Myopia Conclave 2025, and wishing all of us a very, very happy World Optometry Day. So I'm going to be speaking on binocular vision in myopia management. I think there's been a lot of information about the risk factors for myopia and experts speaking about how to do myopia management, how to optimize myopia management in clinical setup. So I'm going to speak about a niche area, binocular vision in myopia. Let's say that we encounter a patient like this, where, as you see here, the child has low myopia with some astigmatism, and then the ocular biometry parameters are provided for your reference. And rest seems to be normal. Yes, there's a family history of myopia, but when you do a cover test, you find there is about 6 prisms esophoria at near. This is when I think most of us, both as optometrists and ophthalmologists, I think probably would pause, and especially when we see that there is an ESO component in myopia, then yes, I mean, now there are myopia control options. We're speaking about optical pharmacology control. There are peripheral lenslets and microcylinders and then defocus incorporated segments. But then what's the impact of all of this on this particular aspect? Is it going to make it better, worse? And of course, orthokeratology and other contact lens options, including multifocal soft contact lenses, are available. But what is the impact of these myopia control options on this binocular vision parameter that you see here? Question number 1. Question number 2, will it worsen? Will it make it better? Question number 3, independent of the myopia control option, is this parameter in itself is a risk factor for myopia progression? Let's say I'm just going to only provide single vision to this child. Am I then putting this child more at risk for myopia progression if I'm not going to be intervening? Should I then go ahead and really introduce a myopia control option, specifically where there are plus lenses incorporated either through one of those novel optical control modality or through an ear addition? So this is where I think our mind should start thinking along this path. And that's what I'm going to do in my next 10 minutes of my talk, to start thinking about the interaction between accommodation and myopia in itself, accommodation, binocular vision, and myopia. Of course, let's all understand that we are not talking about a causal association here, because as much as there are hundreds of research papers that are available talking about binocular vision and myopia, there is still a lot to be understood. So I'm going to be really sticking on to what I know well with respect to my own practice and what's the available evidence that we have when it comes to help when it comes to decision-making process. Okay, I think there is some sort of a delay overall. Okay, please tell me if my slide share stops sharing, because I think there's some delay that's going on here. So as I said, we are not going to be talking about the causal association. Definitely there is something that's going on between these two. So do not never ever say that, okay, esophoria causes progression or accommodation lag causes progression. We are not there yet. I don't think we're going to be there anytime for that matter, because myopia is not as simple as in terms of like making these causative associations. But why binocular vision is important, especially, I put them into 4 boxes. And this is a summary from myopiaprofile.com. First, when you see a child that's at risk for myopia, a child or an adult that's at risk for myopia, when you see a patient that already has a binocular vision anomaly along with myopia, when you're going to be introducing myopia control option, definitely you need to really, really pay attention to binocular vision. And how do you put all of this together in terms of bringing binocular vision into myopia? So this is a patient that I examined a while ago, who's a 13-year-old male, whose primary complaint was intermittent blurred vision at both distance and near. And he was already using a -4 diopters myopia single vision spectacle. And myopia had already progressed within 6 months. And then he's been using spectacles since 10 years of age. There is a strong family history of myopia. And now you already see that there is a very clear evidence of progression. And then you go ahead and then do some of those basic binocular vision stuff. And then you find these parameters. And the one that I want you to pay attention to is the one that I've highlighted in red, which is that 8 prisms of near esophoria. The accommodation parameters seems to be okay, but then the facility, when you use an accommodative flippers, there is a difficulty with minus lenses, which clearly tells us that for this age, a child who's 13 years old should apparently have normal accommodation, especially to be able to clear -2 diopters lenses, but he's not. So there is something that's going on there. Then comes my favorite test, which is the dynamic retinoscopy to evaluate the accommodation lag, and that shows a larger lag. And the impact myopia management guideline is a really nice place to start at this point, where when it comes to managing myopia, it's imperative for us to understand that first it's axial, and then to identify the risk factors, look at who is at risk for progression, then pick the myopia control strategy, and then go from there. So when it comes to picking the risk factors, to me, I think the component that also has to be added apart from biometry and the other risk factors that every other speaker already detailed about is binocular vision assessment. And here I would like to bring in this conceptual model of emmetropization. I know that this graph looks super complicated, and I think my next speaker, Dr. Poling, is going to be speaking about genetically programmed growth when it comes to myopia, or genetic risk factors when it comes to myopia, which is, I think, pretty much established. But I think I want to pay more attention to the visually driven growth. And as you see here in this graph, there is literally very clear evidence between the visual programming in myopia and the genetically programmed ocular growth. You don't have to understand the whole graph, but if logic would tell us, especially when we are looking at a child who is in the progressing year or during the peak period of emmetropization, there is going to be an influence of accommodation and divergence, especially the component of blur that comes both from the relative peripheral hyperopic blur, which then feeds into the accommodation lag, and then also onto the accommodative amplitudes, and its impact on both scleral tension and the crystalline lens thickness. So if we put all of this together, there is no way that we can negate the impact of these peripheral relative blur, accommodation lag, and its impact on the ocular parameters, then interacting with the genetically pre-programmed growth. So definitely there is something that's contributing to the overall progression from the side of accommodation and divergence. But as I said, this may not be a causal association, but definitely this could be a contributing risk factor. And when we look at evidence, there are hundreds of papers, but I'm not going to make it complicated for practitioners here. As you see, there is this discussion about large accommodation lag at near, larger esophoria, reduced facility, and most importantly, intermittent exotropia. Not just esophoria, but children who have intermittent exotropia are also at risk
for then becoming myopic, because these two go hand in hand. But this is just a very, very recent analysis that I did, literally a very quick systematic review using an AI tool for literature review, where, okay, what is really literature at this moment talk about binocular vision and myopia? And there are multiple papers, but I just picked 4 papers. And all I want you to understand is that, which we just spoke, the contribution of retinal blur, which then feeds to the accommodation lag. And then there are other components, spatial frequency, shorter working distances. And those of us who literally saw the boom in myopia progression and the increase in the accommodative spasm during the recent pandemic definitely would not negate that all of this contributes to myopia progression, development and progression. So definitely there is something going on in here. There is a complex relationship. And the standard paper from the International Myopia Institute that specifically talks about accommodation and binocular vision also brings us, you know, the understanding and evidence that definitely lag of accommodation, the impact of spatial frequency at near, which is blur, and shorter working distance can contribute to myopia development. Of course, not a causal association again. So I'm going back to a very, very old paper that I used to really, you know, refer to teach students about the larger prevalence of esophoria and myopia. So these are some of those seminal papers where we started looking at ESO and myopia the moment, you know, we see an ESO in the clinic and the patient is also myopic. But of course, which came first is a question that still remains unresolved. But the COMET study that then evaluated the efficacy of progressive addition lenses and single vision lenses for myopia control did show that children who were esophoric and who had shorter working distances did benefit from progressive addition lenses compared to single vision lenses. And then now I'm taking you to first understanding what's normal, because we all say, okay, there is ESO, there is EXO, but we have to know that what is normal for any given ethnicity and population. This is something that sort of clinicians overlook at some point, because we still, of course, use the Morgan's normative data and data from the Caucasian population. But even when you look at some of those FORIA ranges and facility ranges, you have to use ethnicity-based normative data, and which is something that I've spent quite a bit of time for my doctoral research work. But as part of the work, what I realized is that in any normative study, when you really look at the normal distribution, esophoria generally is very, very rare in any ethnicity for that matter. And that's the reason why when we see an esophoria, we have to just sort of wake up and then say, and then look at, oh, do I have to really do more investigations? Okay, so that's something I want to say. And of course, this is from the Indian population, but if there's someone that wants to investigate in the Middle East and this part of the world, then of course, you know, we can collaborate and do some work. But what we again looked at is what's normal, and esophoria did not exceed 2 prisms in the normative data among children between 4 and 13 years of age. And again, when we looked at near points of accommodation, most of these children had normal responses and normal accommodation. So whenever these parameters are affected in children, whether they're myopic or not myopic, it's important for us to look at. The first message I want to give through my talk is that myopia prevalence is definitely booming, and that's the reason why we are here talking about myopia. On the other side, the prevalence of binocular vision anomalies, especially given the influence of, like, the impact of the pandemic and the completely altered lifestyle post-pandemic, almost among every one of us, even sometimes making these predictions probably might accelerate when it comes to, you know, prevalence of myopia, tells us that there could definitely be an overlapping component between myopia and binocular vision. What I mean to say is that if you see a child with myopia, it's highly likely that this child has a coexisting binocular vision problem. So it's not that they do have to just have a causative association, but they just can go hand in hand. Coming to the myopia control options, of course, there are lots of myopia control options available. But again, from the evidence, there has been a clear evidence that shows that adult myopes that wears orthokeratology lenses do show changes in near foria status and accommodative lags. So again, from a logical perspective, somebody who wears spectacles has the advantage of base and prisms. Now we remove that and we put them onto contact lenses. And if they're already exophoric, then they're going to be more exophoric. So what does this tell us? When you see a patient that has exophoria or already larger exophoria or has convergence insufficiency, then reevaluate them after you fit them with one of your myopia control option. But if they have esophoria, now this is a game for us. If you see esophoria, then orthokeratology or even multifocal soft contact lenses actually could really be a best option in these cases, because they work on controlling the ESO and also the accommodation lag. And this is where we need to sort of, consider binocular vision when we manage myopia. Of course, practitioners are so keen on understanding if there is vision therapy that could be efficacious in altering accommodation in children. But as of now, I don't have a clear evidence to tell you that it works, it doesn't work, but it does improve facility. So once again, going back to what I said, that there could be a large overlap or a high likelihood that binocular vision anomaly and myopia can go hand in hand. There is nothing wrong in working on binocular vision anomalies in myopic children while you're also introducing myopia control option. Again, taking these graphs from myopiaprofile.com, whenever you see an accommodation lag that's more than plus 125, start thinking about introducing one of your myopia control option that works on peripheral hyperopic defocus that can then influence accommodation lag, or introducing near addition through multifocal soft contact lenses or progressive addition lenses. I have prescribed a lot of progressive addition lenses, especially when there is a reduction in accommodation amplitudes and lags of accommodation, and there is some analysis that I've done as well on this subject. But something that I want to also point out to the fact that the increasing amounts or increasing prevalence of accommodation spasm, and some of these spasms that resolves with pharmacological management later then results in an incidence of true myopia. And this once again, of course, needs more evidence, but some data, literally like data from some of the preliminary work that I've done, also shows that it's important for us to closely watch children that has once shown an incidence, a prevalence of accommodative spasm, later then follow them up to see if they develop true myopia. So to summarize my talk, in myopia, there are risk factors that can be modified, which are very important when we are looking at preventative factors. And then there are risk factors that cannot be modified. And then there are risk factors that can be fixed. And binocular vision anomalies comes under one of that risk factor that can be fixed. So it's really important for us to look at the nearphoria, the lag of accommodation, and as I said, intermittent exotropia. At least with the current evidence and the understanding that we have, if we pay attention to these factors and look at how do we integrate and consider introducing an optimal myopia control solution when there is an existing or coexisting binocular vision anomaly, I think this is really a good starting point. There are millions of unanswered questions about like what happens to these parameters as we put them on one of these myopia control option. What happens when there is a decentration, and now that leaves single vision, when we come to these novel treatment modalities, do we have objective estimates to now evaluate some of these parameters, including accommodation lag for that matter? How many children are really symptomatic with larger lags and reduced facilities and all of that, and what's the impact of treating them in the first place? And really, there are children people of determination and children with special needs that naturally also have impacted accommodation and binocular vision and also myopia. So how are we going to treat these children? Of course, all of these are research questions for us to keep exploring. And I think that's what clinical research is all about. But for now, I think we should start integrating binocular vision in myopia management, and happy to take any questions at the end of the session. Thank you.
Thank you, Dr. Hassanuddin, for that informative exploration of binocular vision. Now, may we welcome to the stage Dr. Jan Poling. Dr. Poling is Senior Orthoptist at the Erasmus Medical Clinic in Rotterdam and has a BSc in Orthoptics from the University of Applied Science, Utrecht in the Netherlands. He joins us today to expound on the genetic influence on myopia development and progression. Welcome, Dr. Jan.
Not hearing anything right now, but I must be introduced by now. Do you hear me?
Yes, you are audible.
A little bit worried I'm not heard. Am I heard?
Yeah, yes, Dr. Pauling, you're clear.
Ah,
Yeah.
okay, thank you. Okay, thank you for your kind introduction and also for the possibility for inviting me and speaking here at the Myopia Conclave here. And I want to wish you all a very good evening, afternoon, or morning, wherever you are in the world. So I want to take you to a different field of myopia control, and that is in the Mendelian myopia, so the clinical or the genetically complicated cases in myopia, and I have some clinical data to support that. I want to thank my co-workers and especially Emily van der Sande, who was the PhD student during this time, who collected all the cases, and especially also did some animal work that I would like to introduce you to later on in the presentation, and of course Caroline Klaver of the Erasmus MC myopia group. So these are my disclosures. We are currently involved in many myopia control studies in blue light, red light, in the Sloan studies, as Gabi just explained, but also in atropine studies. I'm a consultant with these companies, and we currently also run a study on atropine. So you've seen these slides many times today, and I don't want to go there anymore, but I would like to point out that this is new data, prognosis projections from the Rotterdam study, and the Rotterdam study is a study that ran from a birth cohort of people who were already born or already being 25 long before the Second World War, so 1920s and 1930s, and we saw that 1 in 4 had myopia back then, and it's steadily increased until we see now that in the younger cohort, we also see that 1 in 3 already has myopia when they were 18. And a lot of pre-myopes are present. So our projections, and looking at other studies as well, is that this cohort will increase to far above 60% of myopia when they reach the age of 25. And if we continue this line, we see 83% in people born between 2040 and 50, and that means that we are running towards or we actually copying Southeast Asia, also in Europe. So is it all about the genes? No, we know that it's not all about the genes. We know it's merely a environmental factor, but I want to highlight the genes because the genes are important. Our colleagues found that about 500, just over 500 genes are involved in determining your genetic makeup for myopia, but this only explains not even explains 20%. So this is not a lot. And if you look at the second graph here on the right, you see that if you have a genetic risk score, so this is 1 means that you don't have a lot of myopia genes, and 10 means you have a lot of myopia genes, and the red is myopia and the blue is hyperopia, you see indeed that there's more red on the right side of the graph. But as you can also see, there is a blue everywhere. So it must be an environmental thing as well, but there are some genetic forms of myopia. So all is still possible, except for the Mendelian myopia. So I just explained that there merely is the problem of environmental factors, but also there are a few, very few, who have a single gene mutation that can lead to very high myopia already very early in life. And some examples of this are Marfan, Stickler. It was earlier discussed that these people have high degrees of axial length or large eyes and high degrees of myopia. So this is also a slide that you are very familiar with, but I want to introduce something new. So we didn't use the myopia contact lenses, the Ortho-K or the myopia spectacles for this research, but we used atropine, and we did not go for the low doses, but we needed the higher doses to be more effective, because obviously there is a dose response, as you see here, and also on the next slide, there's a clear dose response. So these are the control groups on the right side of the slide. The control groups in general, so these were 62 studies. On average, about 0.36 millimeters of annual increase, and you see the annual increase here in 0.01, 0.05, 0.5, and 1. And as you see that these higher doses are more effective. And as you know, these genetically determined myopia, they grow faster and you need a higher dose. And so atropine is definitely the oldest researched method for myopia control. It has trials since the 1970s, and especially the high dose were very popular in the early days. And that's where you see the most effect as well, but it has many side effects. So that is something to take that into account, but I will get back to that later. So the aim of this study is our research question: can the high-dose atropine slow the eye growth in children with Mendelian myopia? So we had children diagnosed with ophthalmogenic syndromes, and each child had a mutation in a single known gene linked to the high myopia of that child. And why does this matter? Because all these children are being excluded from all the studies that we currently know of. And still, we want to do something for these children because it's really important, as they also have a very high risk of becoming very high myopia. And we also see the very high myopes have a very large risk of becoming visually impaired later in their lives. So the participants are the children in the clinic, in the Erasmus MC Myopia Clinic. They were all children with progressive myopia, and they approved. We had ethical approval, and they had informed consent. So we have two study groups: the Mendelian ones and the non-Mendelians, but we match them with age and axial length, so we can actually compare the non-genetic forms with the genetic forms. So we did, all children received the high-dose atropine, either 0.5 or 1%. They all were prescribed multifocal and photochromic lenses to compensate their photophobia and also their reading problems, of course. And then we did examination at baseline, 6 and 12 months. We did measurements with the axial length, cycloplegic refraction, and also we had the axial length growth compared with untreated children from the Generation R cohort. So that's a cohort of children living in Rotterdam. They were naive, not non-treated, and there were also a few high myopes who were not treated by then, because the cohort started in 2002. So these children are depicted here in the graph on the top, and these were not treated. So these are the Mendelian, so they were 6 years compared to the non-Mendelian 7 years, a few more males in the non-Mendelian, but especially look at here at the bottom, you see that their axial length and their spherical equivalent is about the same. And these are the diagnosis of the children and the gene that was affected, and you see these are just a few children. We have 14 in total, so that is, but they were closely matched with the ones who didn't have the gene. available. So this was the baseline. You see here the non-Mendelian and the Mendelian. They had a range from 24 millimeters to almost 29, and it's about the same for the matched controls. So to take this further into the outcome of the study, here you see the outcome of the study and the annual actual length progression here on the left, on the y-axis, and the Mendelian plus atropine and the non-Mendelian plus atropine. So it's about the same. If you had to look at the box plots, they're about the same in both groups. There are some more outliers probably in the Mendelian group, and especially I'll come back to that, what kind of myopes that were, but there were no significant difference in eye growth during treatment, and they could not be controlled as good as your average myope, but it's about 27% in the Mendelian group and 23% in the non-Mendelian group. So there was obviously an effect of gene type on response to atropine. And this is the slide. You see the specific genes. And in general, you could say that children with a retinal dystrophy had slightly more eye growth during treatment, and the children with a connective tissue genes had slightly less growth. And these differences were not statistically significant, but these are small groups, right? So there's some strengths and limitations of the study. So what did we learn? So this is definitely the first study to assess atropine response or myopia control in Mendelian myopia. We have matched securely the non-Mendelian and the Mendelian for the group analysis. And this is the first real-world clinical data, and it's much needed. So some limitation, it's very small sample size. It's only one center where we do a lot of myopia control, and there's no untreated control group. And this is really important for randomized clinical trials and also for ethical reasons. Of course, we did not treat them, but we need some more backup there. So also to do that, we did another study, some animal work with mice, and that is where my colleague Emily van der Zande really did good work. So it is that they used a knockout mice and this is a Donner-Barrow syndrome. It's really a very progressive and extreme axial elongation, and they used atropine in this group, and also the reduction was 28%, also about the same as we see in the other kids. And we had a control group, and the control group in this case was definitely more growth. So even in this case, it's really important to also introduce this myopia control. So my conclusions is that high-dose atropine, at least, or myopia control in general, is very effective in children with genetic high myopia. The response is comparable to non-syndromic cases, but not as good as in your average myope kids. But these children should not withhold treatment based on their diagnosis. So there is some potential for atropine even in severe cases, but future research is definitely necessary, and also future randomized controlled trials. So thank you very much for your attention. I would like to thank my group, and I give the word back to you.
Thank you, Dr. Poling, for your clear presentation. Now, please join me in welcoming our next speaker, Dr. Arunda Agarwal. Dr. Agarwal is not only a vitreoretinal surgeon and uveitis specialist at Cleveland Clinic in Abu Dhabi, but also clinical associate professor at their Lerner Clinic of Medicine. So he is ideally placed to tell us more about the retinal changes in myopia. Welcome, Dr. Agarwal.
Hello, and thank you very much for the kind invitation. Thank you to the entire team of Myopia Conclave for the kind introduction and including me in this program. So I'm going to change gears here and talk about a different aspect of myopia, which is retinal changes in myopia. And I'm going to stick to the basics really to talk to you, to give you an overview about what we expect in the retina in patients of pathologic myopia. In general, there is a huge number of changes that you see from front to the back. Although I'm focusing, really on the back of the eye, I must compile the entire list because some of these changes are related to both front and the back. And in general, one of the most commonest manifestations that we see in the clinic in a dilated exam is presence of a tessellated fundus. A tessellated or a tigroid fundus is the one in which you have a very prominent appearance of choroidal vasculature. And this is a feature of high myopia. Patients of high myopia may also present with tilted optic nerve heads and peripapillary atrophy. And peripapillary atrophy must not be confused in these patients with other anomalies of the optic nerve. So I think careful attention should be paid, especially these patients can have a very large optic nerve. And so the boundaries or edges of the optic nerve may not be very clearly visible. There could be peripapillary retinal detachment. And this is important if, in general, in myopic patients, you will see that the choroid is thinned. But if you have a thicker choroid, these patients could be predisposed to having a peripapillary detachment because often we have seen that the choroid can be specifically thicker in the peripapillary region, but in the rest of the myopic fundus, it is thin. You will also find many patients having various degrees of posterior vitreous detachment. Retinal detachment is a huge topic in high myopia. And of course, they can have other changes of the outer retina and RPE, including lacquer cracks. Lattice degenerations are very common in high myopes, and other forms of degeneration, including cobblestone. And you could also have fuchs spots, which are RPE hyperplasias in areas in CNV. And you have other changes like holes, traction, horseshoe tears, and of course, macular changes, which we'll talk about. In general, the pathological myopia presents with the number of changes such as vitreous degeneration, and vitreous degeneration or syneresis is an important factor or important feature that many patients come to you with this. And of course, you will have myopic foveoschisis and macular hole. These are the two most important macular complications of high myopia. In general, we like to use the term macular tractional, myopic tractional maculopathy because several changes are related to tractional changes, which are both in the anteroposterior and the axial directions. And of course, you have the peripheral retinal degenerations and rhegmatogenous detachments, choroidal neovascularization, lacquer cracks, especially when a crack is passing through the macular center, it can be visually very significant. And of course, it can lead to CNV formation. And posterior staphyloma. Staphylomas can be associated with retinal detachments. Sometimes you could have staphylomas which can be visually significant just because of their mere presence. And they could have changes such as focal choroidal excavations, where you have a very sharp dip of the inner retina into the deep choroid. Vitreous degeneration is vitreous liquefaction, is just a process by which you have the pockets of fluid form in the vitreous cavity. Many patients complain of floaters. These patients complain routinely of floaters that do not go away. And these floaters could be associated with myopia. Of course, trauma, inflammation like vasculitis or uveitis can be associated with floaters. But in general, you'll have young patients with myopia presenting with floaters, and they generally don't go away very fast, and they'll have early PVD compared to the general population. This, I think, is really important for us to understand that when you have a PVD which is symptomatic, that means the patient does present to you with flashes of floaters. And in these patients with symptomatic PVD, remember that approximately 10% would have retinal breaks at the first assessment. And I don't believe that wide field imaging or Optos is enough to screen these patients. So if you have a patient of symptomatic PVD, really you must do a complete dilated exam with peripheral indentation to look for any dynamic changes in the periphery like horseshoe tears. If you deem that there is a break, if you see a break, in general, of course, we try to treat. And high risk breaks are the ones which are associated with vitreous traction in the anterior lip of the horseshoe tear. And in those patients, you would like to treat, because if you don't treat, within a month or less than a month, patients can detach very fast. They can detach. And so if the patient has vitreous hemorrhage, which is avoiding the view to the posterior segment, even then try your best to put the lens and try to do laser. If not, then call the patient very frequently until the hemorrhage settles down and allows you a view to do the laser. If it's a low risk break, there is a low risk of detachment. Low risk break would be the one where there is no traction, which is adequately already supported by a prophylactic buckle. Very rare situations, really. But in those also, I would rather do a laser. If you don't find that there is a break, try to screen again. Usually what I do is I call the patient back in 6 weeks. And some patients, very rarely, you can find a break at 6 weeks, which you did not find before. And this could be because of a delayed change, which can happen because of the mechanics of the vitreous. So in general, if it is a lattice degeneration, I do not advise to treat all lattices. Similarly, you would have also degenerative retinoschisis, some other changes like cystic changes, tufts, and zonular tractions. Of interest really are the lattice degenerations, and lattices can have holes, and in general you would treat lattices only which are associated with holes or with retinal detachments in the other eye. So remember that if you look at phakic rhegmatogenous detachments, 30% have lattices, but less than 1% will develop a retinal detachment. So really you have a large scope here. And the risk of lattice degeneration and development of retinal detachment increases every year. Especially now you have lots of patients undergoing ICL or LASIK or other refractive procedures. So in case you have lattices without any holes, without any operculum or horseshoe tears, you would probably not treat. But in case you have an atrophic hole or a horseshoe tear, you would rather treat. A horseshoe tear for sure you would treat. Atrophic hole, I incline myself towards treatment and do a very targeted treatment. Remember, lots of laser can also cause complications such as epiretinal membrane formation. If you look at the fovea, and foveal changes in patients of myopia can be very significant. And so if the patient is complaining of central vision loss, try to do an OCT. Sometimes they may not have a very distinct visual symptom, but an OCT will show you a foveoschisis. And the prevalence here is quite high in pathologic myopia, in which you find these split in the inner retinal layers. They could be associated with vitreoretinal interface abnormalities like epiretinal membranes, or you could have a traction in the center, and you could also have puckering of the ILM. Most of these patients are surgical and they would benefit from surgery, especially if they are developing changes like macular pucker, epiretinal membrane, or disorganization of the retinal layers. I would rather operate early and get the traction away. Many patients could have associated macular hole formation, and this is an important factor that determines the visual acuity of these patients. So if you have a macular hole, uh, if it is a full thickness hole like shown in the diagram, the only option for you is really to treat patients with surgery and do a ILM peeling with gas tamponade. Remember, only grade 2 or full thickness macular holes are amenable to full vitrectomy. But nowadays, even if you have a lamellar hole with epiretinal proliferation or epiretinal membrane, in a patient who is complaining of metamorphopsia and low vision, I would think of surgery in those patients as well. So I think it's a whole spectrum, macular hole and tractional maculopathy in patients of myopia, and many patients are candidates for surgery. In many instances, we do a serial OCT and look at the changes. And in some cases, when you find that there is progression on the OCT, they should be considered for surgery. In general, unlike dystrophic cases where you have cystic fluid or spaces on the OCT, which may respond to brimonidine, in myopic cases, I don't have much success with medical therapy. And so, like I said, if you find that this is progressive, rather go for a vitrectomy. CNV is a problem in patients of myopia, and in patients where you have lacquer cracks or changes running across the center of the macula, these patients develop CNV very fast. And these CNVs are usually exudative. These CNVs can have a very small looking network on OCT angiography, very minimal fluid on OCT. In fact, you may not find fluid on OCT, and patients just come to you with a drop in vision and metamorphopsia. The rule that we follow really is we treat without waiting for fluid to come on the OCT scan. So if I have a patient with a very distinct a metamorphopsia which is recent in onset, and I see what is called as a subretinal hyperreflective material or SHREM, I would rather treat with anti-VEGF. They respond beautifully to anti-VEGF therapy, and usually I've seen that very few injections are required in macular in CNVs with myopia, unlike AMD or diabetic eyes. And these patients have a very preserved foveal function after that. In fact, even the subretinal hyperreflective material contracts and disappears rapidly once treated. So you may not require several injections in these patients, but you of course have other cases where you may require a higher number of injections. Finally, like I said, CNVs do develop from lacquer cracks. But if you have a patient who looks like this, okay, on with large amount of peripapillary atrophy and depigmented center, almost a punched out appearance, you may mistake these patients for multifocal choroiditis or even punctate choroidopathy, because some of these changes are very similar and they confuse the clinician sometimes for an inflammatory choroiditis. If you look at, especially in Caucasian eyes where the fundus is depigmented, is not very darkly pigmented, multifocal choroiditis without vitritis can very much look like high myopia. And so you should do an OCT passing through the lesions to determine if this is indeed myopia or if it is an inflammatory lesion there of multifocal choroiditis. Like I said, the CNVs in myopia are small, they have less amount of exudation, and they can quickly fibrose. Like in the images shown below, they can form a scar tissue, and if the scar tissue is away from the fovea, usually the prognosis is quite good. And I would treat with either drug, either Lucentis or Eylea or any of those agents which are available. You can treat, and the response is usually very good. So with this, thank you very much again to Myopia Conclave, and I'm happy to take any questions at the end of the session. Thank you.
Thank you, Dr. Agarwal, for that sobering reminder of myopia's effects. Now we are privileged to have with us Dr. Imran Jawad, a consultant pediatric ophthalmologist at Moorfields Eye Hospital. He is going to enlighten us about the UAE's vision, their national strategies for myopia management. Welcome, Dr. Jawad.
Okay, perfect. Is that working for everyone?
Yes, Dr.
Perfect. Thank you so much. So firstly, thank you very much for the very kind invitation. I mean, prior to being a pediatric ophthalmologist, I was once an optometrist. So I'm very honored and privileged to be part of the World Optometry Day meeting. So thank you for inviting me along to talk about national strategies for myopia management. So we're going to have a little journey through myopia and kind of how we implement some of these things at a national level and whether we can indeed make an impact to myopia incidence and prevalence by taking on some of the concepts that we probably heard throughout some of the talks today. So if we, and we've covered this a lot, I think, this evening, but just to hammer home the point that the projections of myopia are going in one way, and that's upwards. So if we look by the global prevalence in percentage terms, over by 2050, we're talking about nearly 40%. But more worryingly, if we look at that in terms of the children who are myopic at that stage, over half of teenage children will be myopic. But for me, the most concerning statistic in this paper that many of us have come across in the press, etc., over the last few months is that almost 30% or almost a third of children aged 6 to 12 will become myopic. And for me, this is very concerning because it's really the young children that we need to worry about. If you become myopic at a young age, ages 5, 6, 7, you are more likely to become highly myopic and therefore suffer from the complications of myopia that my colleagues have already discussed earlier on this evening. And this is not just a localized problem. This is a problem that's increasing throughout Europe, North America, Latin America, and even Africa, where we're expecting up to 10 to 15% of patients of the population, will be myopic by 2050. So really the question we need to know is, or we need to answer is, can we influence myopia onset and progression? And like most diseases, we need to be able to identify myopia into its relevant risk factors. So there are, like all diseases, some non-modifiable risk factors, i.e. if you're female, if you're East Asian ethnicity, and if you have parents who are myopic, and particularly if you have two parents who are highly myopic or had early onset myopia, you're more likely to become myopic. Equally, if you're a firstborn child, or if you're a baby of a very low birth weight, or have had ROP, and particularly those babies that we treat with laser for ROP are more likely to become myopic. But despite that, there are some modifiable factors, and we know that there is good evidence, and we'll explore some of this in the coming slides, about time outdoors and near work, and equally in brackets there, education or academic performance, because you want to encourage that, but can we do that in a safe way? So people have looked at time outdoors, and we'll look through some of the papers that look through this, and there's various theories as to why time outdoors can be so helpful, and people have postulated things like the spatial frequencies, or the fact that you're doing physical activity, or even things like vitamin D or reduced near work. And there's a good paper here which can be found in the British Journal of Ophthalmology, which explores some of these ideas. But essentially, the most frequently cited reason is that bright light increases the synthesis and release of dopamine. And this acts as a stop signal in refractive ocular development. And we know the retina expresses various couple of receptors of dopamine receptor subtypes. And really within all of these receptor subtypes, the D2 receptor that's the most important. And when you have dopamine, you induce choroidal thickening, and that inhibits ocular growth. And this happens via the release of nitrous oxide from either the retina or the choroid, and this therefore slows the development of myopia. And that's probably the most agreed upon etiology. And so people have looked at using time outdoors in various ways, and there's a summary here for studies taking place particularly in China, but one in Singapore, looking at various intervention measures. So we see here that there's studies that range from having children having outdoor activity more than 15 hours a week, to doing 2 to 3 hours of outdoor hikes or sports activities in conjunction with national parks, or an additional 40-minute outdoor activity in school. And so when we look at the data put together, we've in this forest plot here, there's two systematic reviews. And the first of these were published in 2012, showed that for each increase in hours per week of time outdoors, this was associated with a 2% reduced odds of myopia once you've adjusted for potential confounders. And the second is systematic review, which is published here. You can see that there is on the y-axis risk of incident myopia, and on the x-axis increased time outdoors per week. And as we increase the time outdoors per week, there is a declining level of incident myopia. And from the data, we can determine that the increase of almost 9 hours per week, or 76 minutes a day, is needed to obtain a 50% reduction in incident myopia at a population level. And the chance of myopia is reduced by around a third if use time spent outdoors is increased from just 5 hours a week to 14 hours per week. And really a minimum of 8 to 15 hours per week is recommended for school-age children to achieve clinically meaningful protection from myopogenic stimuli. And this is partly where the WHO recommendation of 2 hours of outdoor activity per day would come from. Then we looked at near work through the literature, and we can see that near work distance and duration of near work are key important factors. So this is a paper that looked at 10-year-old children at time points of T1 to T5, which are 6-month intervals apart. And this first graph here in A shows near work distance being less than 30 centimeters and in blue, what near work distance being more than 30 centimeters. And we can see there's a significant difference at all time points between those children at the age of 10 that were doing near work at a distance of closer than 30 centimeters. Equally, if they were doing continuous near work of more than 30 minutes versus less than or equal to 30 minutes, their myopia was progressing at a much faster level. And then in this same study, that they reinforced the idea of time outdoors and recess. And then if you look at this in a kind of systematic review, which was done here, we find that there is a definite trend or a significant trend towards benefits of reduced near work and myopia. So the more near work you do, the more likely you are to become myopic and progress. And what we can see is that 1 extra hour per day spent reading during childhood was associated with a shift in refractive error towards myopia. So 1 extra hour per day spent outdoors, however, was associated with a small shift towards hyperopia. So there's a trend emerging. But the most frequent question that we get asked in clinic is, oh, but can you tell my child not to use a screen? And really the question we have to ask ourselves is it really the screen or is it the near work that's most important? And this is a paper that's published at the end of 2024 as a systematic review and looking at this question, and this is the meta-analysis within that review. And if you look at here in A, which is the cross-sectional studies that were included in this meta-analysis, we found that there's a significant relationship between screen time and myopia. And this was also the case in cohort studies, which is in B. But when we look at the subgroup analysis from the data that we extract, we find that it's not really just screens, but the screen device type that it's pointing towards. So we found that screen time exposure from computers and televisions was more significant related to myopia in cross-sectional studies, so in these ones in A, while not from smartphones. And in the subgroup analysis by geographic region, so if you look at the studies from where the data was collected and the ethnicities and of those patients and where the studies were conducted, there were significant associations in East Asia and South Asia, but not in Europe and America. And this is slightly contradictory to the previous meta-analyses earlier on by Carla Lanka, who's a colleague here in the UAE, and a paper in 2021. And we have to be careful that if you just restrict screen device usage alone, well, could this just result in children returning to previous habits that contributed to myopia, such as kind of long time near work associated with reading a book, for example? And in the school environment particularly, there is a tendency for children with longer durations of education to exhibit higher rates of myopia. And if you look at this in South Korea, we see that in South Korea, 75% of school children receive private tutoring for nearly 7 hours a week on top of their school day. And they have a 97% prevalence of myopia among young males in Seoul. In fact, I think being a tutor in South Korea, that contributes something like 2% of the GDP in that country. So in the rest of the world, so outside of East Asia, we have some catching up to do. However, in 2018, the Chinese Ministry of Education imposed controls on the use of electronic products, and they stated that the single use of electronic products for non-learning purposes should not exceed 15 minutes, and the cumulative data should not exceed 1 hour. And equally, the WHO has proposed a recommendation to limit screen time to no more than 2 hours per day in 2020. And this is not just because of myopia, because there is sufficient evidence to demonstrate the relationship between excessive screen time and other negative health outcomes in children, such as hypertension, insulin resistance, being overweight, having sleep disorders, and indeed depression. And really, it's important to determine the impact of screen time on myopia onset and progression. Most studies that even the ones that we included in that meta-analysis, use self-reported questionnaires. And no study has really looked independently at the impact of smartphone use. That hasn't yet been explored. And so if we put some of the stuff that we've just discussed together, this is a summary of a paper that we put together for a pediatric journal. So this is in China during COVID. And it looked at the age of a child and then the mean refractive error in 2020 compared with the most myopic outcome in the previous 5 years. And so during this time, we know that children were homeschooled in front of a screen. They were not going outdoors because of lockdown. And so all the things that we've spoken about as being potentially myopogenic were happening. And we found that in these young children, especially the ages of 6, 7, and 8, there was a 16 up to a 21% prevalence, of myopia in the year 2020 compared with the previous 5-year high. So a massive increase. And that could just be due to the environment or the environmental changes alone. So what have other countries done about this? So if you look at the Singapore National Myopia Prevention Program, they had an intervention which was education and vision screening. So the education was targeted. It was targeted towards children and parents and teachers. And they were encouraged to facilitate an environment that promotes good eye care habits. They even had a representative called Captain Eye, who's a bit of a mascot for this campaign, and children were absolutely engaged in promoting habits that Captain Eye would find good for your eyes, and they were habits such as getting time outdoors and managing your near work and your near work distance. And they use mass media to propagate the message of good eye care habits among the general public. Now, it's no point having education if you cannot determine the impact of any intervention. And so they also had an excellent vision screening program. And this is a school-based vision screening program. If it was normal, then that's fine. You just had an annual review. But if it was abnormal and they were over the age of 7, they went to their optometrist. And if they're under the age of 7, they went to a specialist refraction clinic where they followed this pathway. And if you look at what happened, we can see that from the onset of the school screening program, the blue bars here is for secondary school children, and the red bar here is for primary school children. And there's a consistent decline in the prevalence of myopia from 2004 to 2007, where it kind of stabilized, which is excellent. But the same impact wasn't seen in secondary school children. And this could be just because those behaviors changed as you get older and your academic needs change, or it could be the fact that maybe these behaviors are less impactful in children that are a slightly older age. And if we look again in Taiwan, they had the Tian Tian Outdoor 120 program, and this was introduced here in 2010, and children were the following behaviors were basically encouraged. They were encouraged to gaze into the distance. I did some eye exercise involving massage surrounding the orbital rim. I'm not really sure what all that's about, but someone can perhaps enlighten me. They ensured that the classroom light intensity was at least 500 lux. And they change the table height according to the student's height. So if you're very short and you sit at a standard height, then by definition, you're going to have a very close working distance. So they were able to adjust the height of the table to the students to maintain a safe working distance. And they also did the 30-10 rule. So 30 minutes followed by a 10 minutes break during any near work activities. And you can see here that up to 2010, there was a consistent increase in the percentage prevalence of myopia. And after this was introduced, we saw a consistent decrease. So from a peak of 50% trending down towards 46% in 2015. So what does all this mean for us? So in the UAE or around the world, where we do not have public health interventions, well, I guess the first thing that we really need to do is we need to determine the rates of myopia in our local populations. And we need to do this in a very precise way before we can measure any public health impacts of any intervention. We can then introduce public health messaging around time outdoors and near work. And really, I don't think there's any debate around the benefits of these things, especially for incident myopia. We need to engage in effective communication amongst key stakeholders. So that's, education providers, parents, children, and public health officials in relative countries around the world. We need to ensure there's access for screening and refraction, at least annually, and that should be available for every child. And we need to ensure that there's access to myopia management, because we have a whole armamentarium of myopia management available, but it's no good if it doesn't actually reach the children who need it. And we need to work collaboratively to work towards detecting trends and implement strategies. So thank you very much, and I'm sure we'll take questions at the end. Thank you.
Thank you, Dr. Jawad, for sharing the UAE's priorities with us all. Now, please help me welcome Dr. Rajiv Prasad to our conclave. Although, as the director of the World Council of Optometry, the president of the Asia Pacific Council of Optometry, and the secretary of the Indian Optometric Association, he surely needs no introduction from me. Tonight, Dr. Jawad will share his protocols and best practices in myopia control and treatment. Welcome, Dr. Prasad.
Thank you so much for this wonderful introduction. So, is my screen visible?
Yes, sir.
Perfect. So, I think by now a lot has been discussed about myopia and what are the best ways to move forward. So I'll be talking a little bit, just adding on a few things, on the protocols and best practice management, in myopia management. So by now it is very clear that myopia is no more just a refractive error or more than just being nearsighted, because it's come along with increased risk of retinal detachment, increased risk of myopic macular degeneration, increased risk of open-angle glaucoma, and increased risk of posterior subcapsular cataract. And this means that this equates myopia to just blurred vision that can easily be fixed with traditional glasses or contact lenses. So the problem of myopia is mostly all about, we are more concerned about the size of the eyeball, which is rapidly increasing, and that leads to, getting weaker and weaker of the eyeball, which is sight-threatening. Complications associated with high myopia is really high. As I mentioned, macular degeneration, retinal detachment, cataract, and glaucoma are some of the key. So what leads to the development? So by now we know that genetics is one of the factors. If neither of the parents is myopic, then chances are really, really less. When either of the parents is myopic, the chances are 3 times higher. And if both the parents are myopic, it is 6 times higher. Another key component which contributes is environmental factors. So positive correlations is intelligence, academic advancement, advocations requiring near vision use, professional school, confined to smaller spaces, greater time doing near work, which has increased risk of myopia, and then accommodation, greater lag of accommodations, high ACA by A ratio, more esophoric, decreased accommodative amplitude, which worsens accommodative responses. And third is definitely the combination of the both. So what leads to development is definitely, we know, parental myopia, education, time spent outdoors. I think the previous speaker, really gave a wonderful detail about the time spent outdoors. Age is definitely a factor, and then socioeconomic status and cluster difference. When we talk about cluster difference, so researchers often use cluster analysis to identify patterns of myopia progression in different population groups. Differences between the cluster can help in risk stratification and treatment planning. Factors such as genetics, axial length, growth, environmental exposure, and binocular vision status may define these clusters in detail. So optical blur produced by the lag of accommodation may be definitely the signal that drives excessive eye growth. In April 2021, the World Council of Optometry passed a resolution that declares support for myopia management as a standard care. And the evidence-based standard of care combines 3 M's as a key components: mitigation, measurement, and management. Mitigation, wherein optometrists educating and counseling parents on children during early and regular eye exams. And when I say eye exam, it has to be a kind of comprehensive eye exam, including binocular vision. And that's one thing most of the time we miss that out. Then lifestyle, dietary, and other factors to prevent delay onset of myopia. When it comes to measurement, we often miss out this, optical biometry, the measurement of the eyeball. It is just the refraction which has been done. So evaluating the status of the patient during regular comprehensive vision and eye health exam is really important. Management-wise, optometrists addressing patients' need of today by correcting myopia while also providing evidence-based interventions like contact lenses, spectacles, pharmaceuticals, which has definitely showed that it slowed down the progression for improved quality of life and better eye health today and into the future. We are really concerned about the studies which has come up and which says that the trends of myopia prevalence is really growing. In 2010, it was nearly 28%. And now WHO has already defined it by 2050, it's nearly 50%. So even at that 50%, what is concerning more is 1 billion will be high myopic, which is 10% of the entire one. And this was done by, Holden et al. In 2016. Especially prevalence of myopia is highest in East Asian countries. And recent data also shows that it is not only restricted to Asia, but it is spreading towards Europe, which is 40 to 50%, and especially in 25 to 29 years of age group. So we have to work on a holistic approach towards myopia management, because we really need to understand what are the key factors and how we can best manage. So we all know by now that optical, pharmaceutical, and behavioral interventions are the key. Evidence-based methods such as myopia control, ortho-K, and atropine therapies are examined along with the role of daylight exposure, digital device use, and ergonomics modification. Regular and axial length monitoring and personalized treatment plans are crucial for slowing the myopia progression. By combining scientific advancement with patient education, eye care professionals can implement a comprehensive, standardized approach towards effective management myopia and reduce the associated risk. Evidence-based, we are in the world where we always talk about the evidence-based. So myopia has reached epidemic proportions worldwide, which has made important that evidence-based approach is really required towards the management. Special focus is given to the patient-centered strategies, including early detection, lifestyle adjustment, and importance of axial length monitoring in determining treatment efficacy, with the emphasis on clinical guidelines and combined therapies approaches. These resources serve as a practical guide for the eye care professionals, leading to slowing the progression. And standardized protocols for myopia management is really important, because at this moment, there are a lot of different studies which is going on. And so far, not yet, research is on, but not yet a protocol has been, identified. Still it is on, and I think, still we are into a little gray area where things are not very clear. So key components such as so far which has been identified is definitely as axial length monitoring and combination therapy approaches are discussed to ensure optimal outcome. Now, when it comes to protocol, we really need to work on a very clear guidelines which focus on early detection, risk assessment, intervention strategies, and long-term patient care. History taking, very, very important. Doing a great refraction, binocular vision assessment and accommodation test, slit lamp examination, corneal topography, and definitely optical biometry, axial length measurement. Selection of treatment strategies is like predicting the progression rate. A lot of devices has come in these days which predicts it. Selecting a treatment protocol which leads to lifestyle intervention, optimizing the environmental influences, optical interventions, multifocal spectacle, contact lenses, and ortho-K, and definitely pharmaceutical interventions, which is atropine. So baseline of refractive error is really important. Binocular vision status, ethnicity, safety, compliance, and cost consideration is definitely important. There are many studies which has made it clear that near work and outdoor activity has a great role to play in myopia management. Ortho-K, a wonderful tool which has come up, and it's been there for ages, but probably now post-COVID, I think, there is a lot of push on ortho-K and myopia control. Ortho-K lenses. So these rigid lenses are worn overnight to reshape the cornea, and which has proven that this slows down the progression by 30 to 55%. And beside that, in terms of axial length, it reduced by 0.36 mm to 0.633 mm over the 2 years. Works best if started early in fast progressing children. Safe and proper hygiene and regular monitoring is indeed needed and ideal for motivated patients and families, because a patient who is not willing to go for overnight lenses, especially in the country like India, it becomes a big challenge. Optical interventions, a lot of ophthalmic lenses is already in the market, but yes, the previous concept of myopia undercorrecting is not effective and is definitely not recommended these days. So bifocal progressive additional lenses offer small benefit, definitely better with specific children. These are limited with effectiveness. Special lenses that slow down myopia by 52% and eye growth by 62% over 2 years. Some children has no progression at all that has been seen. Aspherical lenslet designs, DIMS design, and other approaches using peripheral myopic defocus shown the reduced axial progression up to 67% in some studies, and best use suitable for younger children for those not ready for contact lenses or drops, non-invasive, easy to wear options. Multifocal and soft contact lenses already is existing with daytime lenses that slow eye growth by creating myopic defocus in eye periphery. There are trial has been done, dual focus lens design, and low dose atropine. Still in low dose atropine, there are studies going on between efficacy rate of 0.01% to 0.05%. And little controversial, definitely the red light therapy. So vision therapy is definitely not the first line treatment for myopia progression, but it focuses mainly helps with accommodative dysfunctions and binocular vision issues like eye strain, convergence insufficiency, and all. And what it does is improve near point focus, eye coordination, and visual comfort. And it can definitely benefit children with excessive near work strain, reducing accommodative lag, and a possible contributor to myopia. Thank you so much.
Thank you, Dr. Prasad, for that practical assistance for us and for our patients. Finally, please welcome all the speakers back to the conclave for a panel discussion led by Dr. Rizwana. Thank you, everybody.
Thank you, Claire. This was an excellent session. I thoroughly enjoyed. Okay, I think they're all being put. So we don't have any questions from the audience. So I think all of these are, I just have a couple of questions. First to Dr. Pauling. Very, very interesting presentation. And of course, the Mendelian myopes tend to be high myopic. In your sample, you had almost like about -7 diopters, if I'm right, matched, right? But then what is your prediction, let's say, in general, when they are high myopic? Do you expect atropine to work in similar ways, like how you observed in the current sample?
Yeah, we we think it's about the same mechanism. They only work as your in normal studies you always have the poor responders, and these would be the poor responders. So they work not as good as you would expect. And as you say, there were already -7 at baseline, and the children were 6. So these were really your extremes. And even in these cases, we see that. If we compare them with non-treated normals in a cohort, they do better than that. So yeah, it's always better to do something than nothing, and especially the animal work supports that. So also in mice, we see the same. And then we can easily manipulate. So we can create a very high progressive myope mice, and then just treat one eye and not the other eye. And then it's both in females and males. You see the same effect that there is some treatment effect. So actually. Atropine is very robust. It does the same. It doesn't matter if you're genetically driven. It does the same, and I believe that's for myopia management in general. but that needs to be seen, because that we did not do. But I do think it all helps. So I give these children also multifocal contact lenses on top of their atropine to combine effects to get even more effect.
Yeah, so that's what that was my next question, because these are generally resistant to other modifications, right? That works in the rest of the cohort. Okay, that answers my question. Thanks, Dr. Pauling. To Dr. Imran. So where do we start now that we have so much data and evidence? If we have to start, especially from the stakeholders' perspective, from the eye care practitioner side, where do we start with respect to implementing it in this part of the region, in this part of the world?
I mean, there's two things really. I mean, the first thing, I guess, my talk was mainly around population level data. And I guess the first thing that we need to establish is what is the prevalence of myopia where we are. And so before we can do anything else, before you determine the impact of any intervention, you need to know where you are. So I think there's some countries, so Jean and the team in Rotterdam, amazing. We have some good data in Germany. There's some emerging data in the UK. Obviously, East Asia are miles ahead. But through the rest of the world, we really don't know. And we have estimates, but we really don't know where we are. So I think previously, as pediatric ophthalmologists, we've been very much focused on vision screening for amblyopia. I never really thought of myopia as something that would be a public health concern, or indeed something that would be anything we need to worry about. We really didn't even think of it as a disease. So I think if we're going to do anything meaningful, I would say the first thing we need to do is to understand the prevalence of myopia, engage with parents and stakeholders and educate them about why it's important, and to have conversations with educational leaders and to learn lessons in those countries that have already done it really well, like in some of the examples we've already seen, Singapore, Taiwan, China, for example. I mean, some of the measures in China are quite extreme. So they've got some reading bars in their classrooms and things, which I'm not sure how applicable they will be, but there are definitely lessons that we can learn. Yeah, for sure. Yeah.
Thank you, Dr. Imran. Do we have Dr. Aniruddha Agrawal here, or he's not there? Okay. To Dr. Rajiv then. So how successful, I mean, as a clinician, how successful you would consider yourself to be in implementing all the 3 M's of the World Council of Optometry with respect to spreading awareness amongst your counterpart and in India?
Yeah, I see, in my practice, I think what I have, understood in India is the key component is most of the patient visiting the practice is not really aware of the current status of myopia and where it will lead to. So I prefer more to, talk more about, in terms of educating the parents that why are we so concerned? Why are we, going ahead with certain strategies? And what are the repercussions if we don't go for it? Beside that, when I also work on, in terms of a school eye health program, so I just don't go on, quantity of vision that, okay, you read by 6x6 and it's done. I really go for, comprehensive examination using flippers and, doing a full binocular vision assessment with my team so that I understand beside amblyopia and all of the things we are doing. So that, there are a lot of patients who are with amblyopia and high myopes, and most of the time in school screening, we don't talk about it. So I prefer to do a screening where, I do a lot of counseling with the school also, that these are the children who are being identified with, myopia or amblyopia. I try to call their parents, do a little bit counseling, and wherever they want to go, that's up to them. But, I think educating to the parents is really, really important. And so far, we have a good success. The only biggest challenge in India, what we face is the legislation, because optometrists are not allowed for, certain medications, and that restricts us to provide, atropine or any other things.
Thank you, Dr. Rajiv. This question I had for Dr. Aniruddha, I think I'm going to just ask Dr. Imran so that we, with respect to the retinal complications. So let's say we see a child who's myopic and also has a retinal complication, but not severe. Let's say lattice degeneration. Do you recommend more frequent follow-ups, compared to the rest of the general follow-up?
No, I mean the only time that I worry about kids who are myopic is if they have peripheral retinal changes. That's things like peripheral retinal avascularity. So you're worried about things like FEVR, which is a progressive condition, can lead to retinal detachments, and there's often an autosomal dominant family trend in this. Generally, if you've got lattice, you've got snail track, etc., these don't lead to childhood retinal detachments unless you're predisposed. You've got something like Stickler's syndrome or something else. And there's designated pathways in most countries for these children. But really, I think there's a really nice white paper by Ian Flitcroft and John Ainsworth, and they looked at kind of when you should worry. And a kind of rule of thumb that I try to follow in my practice is if you are more myopic than your age in years, up to the age of 10, then there is something else going on. If you're -4 and you're age 3, you've got something else going on, and perhaps it's those Mendelian traits that Jan spoke about, or equally. If you're highly myopic and you're under the age of 10, then I would look for other causes. But my most worrying thing for these kids is looking at their peripheral retina. And that's what you don't want to miss. So, I dilate the patient, look at wide field retinal imaging. I think that's a really good thing to do for these children.
Thank you. I think
I would say the same indeed, what Imran said about we offer genetic testing in children higher than their age, or myopia higher than their age, if they're above the 99 percentile and not responding properly on atropine, or if there is a myopic parent higher than -10, those 3 cases, or if there is a suspicion, night blindness, things like that, other suspicions, in those cases we offer genetic testing, and 1 out of 5 patients have a genetic disorder or Mendelian disorder. It's quite high.
That's really helpful. So with that, we come to the end of our session, and I'm going to hand it over to, thanks to all the speakers. I now invite Mrs. Devakani to take this from here. Thank you. Thank you, everybody.
Okay. Thank you, Dr. Rizwana. And thank you. We have come to the end of the session, and I'm happy to announce a leaderboard champion, myopic hero of the day. Still remains with Mr. Dinesh Singh with the score of 10,866. Congratulations, Dinesh Singh. And we have come to the end of the session, and I would like to take this opportunity to thank you all. Okay, so on behalf of United Optometrists Forum, I'm delighted to extend our heartfelt gratitude to each and every one of you who has supported the journey. Your contribution and enthusiasm have been invaluable in making this event a success. A special thank you to Zeiss Vision Care for their unwavering support and commitment. Our sincere appreciation also goes to Amico Alcon for being with us, and we are truly pleased to have Esila Luxottica join us for this event. Your support has been instrumental in advancing our mission and continuing our important work. We extend our deepest gratitude to our distinguished speakers for sharing the expertise and invaluable insights. Thank you for accepting our invitation and for being here with us today. It is an honor to learn from you all. To our attendees and participants, your engagement and enthusiasms are what make these sessions truly impactful. Thank you for your unwavering attention and active participation throughout the event. A well-deserved round of applause goes to all our committee members of United Optometrists Forum for their dedication, hard work, and relentless efforts in ensuring the success of this event. Special thanks to our event management team, Peppo, and IT team for their seamless coordination, meticulous documentation, and for ensuring the smooth flow of the event. Once again, thank you all for being part of this journey. Your support and passion drive optometry forward, and we look forward to seeing you at our future events. I would like to hand over to Swarna Kamal for the closing remarks.
Dear esteemed speakers, honored guests, and visionary attendees, what an incredible day this has been. As we come to the close of largest online myopia event here in 3D Metaverse, I stand before you filled with immense gratitude and pride. We have witnessed a truly global collaboration with more than 30 distinguished speakers from around the globe, 1,700 plus registered attendees, and an outstanding 1,400 plus live audience engaging in insightful discussion, groundbreaking research, and cutting-edge advancement in myopia management. This event is more than just a conference. It is a movement that unites optometrists, researchers, and industry leaders to combat the global myopia epidemic with science, innovation, and unwavering dedication. A special acknowledgement to all our speakers who have shared their expertise, experiences, and passion today. Your knowledge has empowered and inspired us to take proactive steps in myopia care. To our attendees, your engagement, thought-provoking questions, and commitment to learning have made the event a resounding success. We are pleased to announce that this event is officially accredited by Dubai Health Authority DHA with 5.5 CME credits. Certificate of attendance and CME certificates will be delivered in your registered email ID within 21 working days from today. Before we conclude, let us celebrate the dedication and impact of individuals who have truly stood out today. The Myopia Hero of the Hour and the Myopia Hero of the Day have been carefully selected for their outstanding contributions and engagement. Winners will receive an official email notification with the details regarding their prizes. Congratulations to our heroes. To our event organizers, technical teams, and sponsors, your efforts behind the scene have made this immersive 3D metaverse experience seamless and engaging. Thank you for bringing this vision to life. As we wrap up this extraordinary day, let's carry forward the momentum we have built. Let's take today's insights into our clinics, research labs, and communities. The fight against myopia is a collective effort, and together we are shaping the future of vision care. Thank you all for being part of this remarkable event. Until we meet again, whether in person or in the metaverse, keep striving, keep innovating, and keep making a difference. Wishing you all continued success and global health. With gratitude and respect, myself, Swarna Kamal, President of United Optometrists Forum, signing off here. Goodbye, everyone.